Good afternoon. Hello, hello. Good afternoon. Thank you for coming to the first annual, hopefully annual, 2015 MedWest Speaker Series featuring therapeutic modalities. We have 3 guest speakers that have flown in to speak to us today. Before we get to that, though, I'd like to welcome you all for attending live in person. For some of you that may not know this, we are broadcasting this live to people across the country, some folks in the States, and I'm not too sure there's a couple people in Europe, but if there are, hi Europe. Anyhow, this is the first time we're doing it, so we hope it runs smoothly. If you have any questions, again, just let us know. Again, thanks for attending. Everybody out there in the virtual world, thank you for attending as well. I'd really like to thank MedWest for being one of the sponsors. I'd really like to thank Mount Royal University for hosting, the Alumni Association for their donations as well, and all the volunteers that have made this possible. So I'd like to give them a round of applause. Thank you. Just some logistical things. First of all, we have 3 speakers and we'll have a break in between each of the speakers. So you'll have an opportunity to grab some refreshments, go to the bathroom and get your texting in. But we'll ring the bell. Nick, my man, will ring the bell to get you guys back in. This is what it sounds like. Fantastic. So when you hear that, please hurry back. We're going to start right away and try to stay on time. We will have a question and answer period available depending on how time flows. We'll have that facilitated by Mark Lefebvre, and we'll kind of play it by ear, but there will be a longer question and answer period at the end. So if you do have questions, make a note of them. You'll have the opportunity to ask. We will address online questions as well. For those of you watching this webinar, you do have the online question submission form, so complete that. We will get those questions, and again, we'll play it by ear. We will address your questions when you have them. A couple of things, refreshments are in the back. For those of you that haven't been here in a while, the bathrooms are just out the doors to the right. And because there's a virtual audience, we do have a very sensitive microphone up here. So if you can keep the side chatter to a minimum, if you can, that would be greatly appreciated. Thank you. In saying that, the last thing I just wanted to say is just a quick little story about how this all developed. And I told this story to the speakers last night at dinner. I tell the story to Mark all the time. It actually started on a dirty napkin. We're just brainstorming ideas. There was a napkin on my desk, and Mark came in and he's like, "What are we going to do for the AGM?" And I was like, "I don't know. What do you think?" So he's like, "Modalities. There's a lot of great stuff out there." So I was like, "Well, who do we contact?" And we just wrote down some names. I can't find the napkin, but 3 of the speakers' names were on that napkin, and I just randomly, and I think random is a good word, I randomly emailed them. They had no idea who I was. I had no idea who they were. And they said yes. I ran to Mark's office, and I'm like, "Okay, so they said yes. What do we do?" And this is what happened. The side note to that story is I went to pick them up at the airport the other day. I have no idea what they looked like. They Googled me, so they had an idea what I looked like, but I didn't Google them. So I'm standing at the airport like this, and this is the actual sign that I was using. I was a little bit late, so I'm standing there like this, trying to see if I got an email. And then Jim says, "Dennis," and I look up and I'm like, "Oh, it's you." And then he goes, "Oh, your sign's upside down." And then I went like this, and I went, "No, it's not." Fine me. Anyhow, that was my story. So let's just get this talk on the road. I want to introduce Brita. She's the president of the Alberta Athletic Therapists Association, and she'll be doing the introduction to the first speaker.
Thank you. So before I begin and give my first introduction, I just want to take a moment to say thank you to Dennis Valdez, who definitely championed and took a leadership role in organizing this event. So can we just give him a round of applause? So it's great to see so many of you out here. I'm really excited to see you all here and for this event. So most of you know I do teach modalities as well, and we have 3 rock stars in the modalities world with us. This is a chance of a lifetime, and I'm glad you're here to share it with us. So our first speaker is Dr. James Ballou, and he comes to us from the University of Indianapolis. He has a long list of accomplishments and also wears many hats. In wearing those many hats, he's a full professor at the Cranett School of Physical Therapy. He also holds his Bachelor of Science in Physical Therapy from Marquette University. He has his Master's of Science in Orthopedic Physical Therapy. And he is, most importantly, the co-author of this textbook, Modalities for Therapeutic Intervention. So if you didn't bring this textbook today, you missed out on your chance to get it autographed. If you already don't have it, I suggest it's a good bedtime read. Go on and get one. Now I'm going to welcome him up to give us a presentation.
Well, good afternoon, and thank you for your attendance, and perhaps more importantly, your interest in therapeutic modalities. It's a great pleasure for me to be here. It's my first trip to Canada. I'd like to thank the Alberta Athletic Therapists Association, MedWest, Mount Royal University for the sponsorship of this. And I definitely would like to thank Dennis and Brita and the rest of their colleagues for their outstanding communication and organization in putting this event on. I can honestly say that this has been one of the most well-organized events that I've participated in. I'd like to talk with you this afternoon about neuromuscular electrical stimulation. I'd like to start by defining that as the use of electrical currents for the purposes of increasing or retarding loss of strength. And I'd like to define the primary outcome measure of NMES as muscular force, or increase in muscular force or strength. And I'd like to differentiate that from many of the secondary outcome measures that are used that may include things like walking speed, pain, ligament laxity tests, time on crutches, time to treadmill, subjective questionnaires. And I'd like to bring your attention to this because oftentimes the secondary outcome measures are what's used to interpret the efficacy of NMES when its primary given outcome measure is suggested to be strength or force. So the question I'm going to start off with in a brief travel through the recent literature before getting out of the literature so as not to drown you in data and significance levels, etc. Who benefits from NMES? Well, I'd like to use this model to present this to you. Recently, a model was created from patients progressing to total knee arthroplasty that attempted to delineate or identify the primary underlying factors that lead to the precipitous loss in strength following the total knee arthroplasty procedure. These two intrinsic factors were identified as, these two factors were identified as one intrinsic at the level of the muscle fiber, that being fiber atrophy and fiber loss, and extrinsic loss or neural factors, primarily due to muscle activation and deficits noted at the motor unit level with the declining ability to activate or recruit motor units. While this model was originally created from patients proceeding or advancing on to total knee arthroplasty, it lends itself extremely well to other populations. So looking at our graph here, immediately post-operatively or post-injury in this case, there's a significant drop or reduction in strength. In the ensuing or initial period, and I'll use this cursor for all the people tuning in the first several weeks following injury or surgery, that decline in strength is largely related to recruitment factors, an inability to fire motor units, recruit them with the same synchrony that was capable beforehand. But as time progresses down our x-axis, and as we proceed from left to right, we see that as time proceeds, the intrinsic factors become a more significant factor with fiber loss and fiber atrophy. So in some manner, we can say that it is the neural factors that beget or contribute to or lead to the intrinsic factors or loss of fiber size, number, etc. Now, when we peruse through the literature and see, it is in this initial few weeks of strength deficit following surgery or injury where the evidence for NMES is most robust or most strong. If we look at the literature for NMES and look at the time sequence for when the NMES was administered, and we see that it falls outside of approximately a 6-week window, then we see that the efficacy for NMES is dramatically reduced. This is a factor I point out that's oftentimes overlooked in many of the reviews, many of the conclusions that are used to decide whether or not to approve, refer for, or pay for NMES. So more recently, there's been an increased interest in research of the efficacy of NMES, and particularly in specific groups. So we'll talk about some of these systematic reviews in some of these patient populations right here. Throughout the literature, there continues to be problems, largely summarized as conflicting evidence. There's substantial variation in all sorts of aspects of study, from study design, patient selection, patient follow-up, and most certainly parameter selection, design, application, administration, down to electrodes, etc. Despite these deficiencies, there's still some strong consistencies that allow us to extract some information from the literature to be able to use our to guide our clinical decision making. So in 2011, a systematic review was published that assessed the use of NMES with rehabilitation versus rehabilitation alone in patients undergoing ligament and meniscal injury. They originally looked at 406 studies, but after administering the inclusion and exclusion criteria, that was whittled down to 19 studies. The outcome measures that this systematic review used to assess efficacy for NMES included quadriceps strength and a slew of what I will call the secondary outcome measurements, including performance tests, the KT1000 ligament laxity test, single limb stance time test, and walking speed and ROM arm. So the systematic review looked at those 19 studies and came up with a finding and suggested that strength was better in the group that received NMES at the 6-week period, no matter how it was measured, isometrically, by manual muscle test, or isokinetically. And it was reported as the evidence was best for NMES when it was applied within and over that 6-week period. So the subjects receiving the NMES showed functional improvements beyond the strength increases in strength. They showed improvements in range of motion, activities of daily living scales, walking velocity, and again, the single limb stance time test. But there were no significant differences between the two groups in parameters that were used to assess efficacy of NMES that included the number of patients using crutches, the number of patients progressing to treadmill, pain, or the KT1000. And I would suggest or ask you to consider, are those appropriate measures to assess the efficacy of NMES when its primary given purpose is to recruit or activate skeletal muscle for the purposes of increasing or retarding loss of strength? So the final conclusion from this systematic review for this patient population, or patients with ligament or meniscal injury, is that NMES combined with rehabilitation is better than rehabilitation alone up to 2 months. And I'll point out here that this is where sometimes people argue that if there's no difference at 6 months or 1 year or 2 years, and more commonly 1 year and 2 years often assessed, if there's no difference at 1 and 2 years, then does that warrant the use of NMES? What we know is that the patients that receive NMES, they reach the markers of functional improvement sooner than patients not receiving NMES. And in quality of life scales, patients receiving the NMES score higher on those. Now, in 2011, we also saw a systematic review that assessed the efficacy of NMES in patients undergoing ACL reconstruction. 301 studies were initially identified, and that was truncated down to 8 randomized controlled trials. The findings from the systematic review suggested that studies reporting increased strength also showed the subjects had the fewest number of sessions and the shorter duration of the rehabilitation period. The patients not demonstrating increase in strength or the inconclusive studies, patients were all self-treated and they all used battery-powered devices. 2 very contentious considerations in the use of NMES. The conclusion of this systematic review for patients undergoing ACL reconstruction is that best evidence suggests 4 weeks of clinically supervised NMES along with rehab. 2 of the 8 studies, that's the 2/8, 2 of the 8 studies reviewed suggested that NMES was not necessary for successful rehabilitation of the ACL reconstruction, but the effect sizes of all studies clearly suggested that NMES with exercise is warranted. Now in 2010, a very damning Cochrane review came out that looked at the use of NMES in patients that had received total knee arthroplasty. The problems with this review are very straightforward. They only included randomized controlled trials and controlled clinical trials. They came up with 2 studies that they then based their entire summation and their summation on. These 2 studies, while they had their differences, their poor description of parameters, they used patients with end-stage OA, the ones most likely to proceed to the arthroplasty, and the conclusion from this Cochrane review that was picked up by the media and perpetuated throughout the United States was that there is insufficient data to recommend for or against the use of NMES for quadriceps strengthening in these patients undergoing total knee arthroplasty. Now, which side of that suggestion do you think the third-party reimbursers or the insurance companies picked up on? A unilateral myopic view. So I say that's why I preceded this by saying this was a very damaging or very damning Cochrane review. However, there was rebuttal to this. Since 2010, there have been 4 randomized controlled trials that looked at the use of NMES in patients undergoing total knee arthroplasty. NMES on postoperative strength and function in patients undergoing the total knee arthroplasty, 2 out of those 4 studies suggested NMES has a significant advantage over no NMES for increasing performance, including strength and a variety of the secondary outcome measures that are more related to strength than are not, such as pain or ligament laxity. 1 of the 4 studies reported that NMES fails to increase performance better than progressive resistive exercises alone, but the assumption there was that the patients were able to complete the progressive resistive exercises, and if they weren't able to complete the progressive resistive exercises, they weren't included in the study. I'll come back to why that's significant and who NMES is targeted to help. 1 of the 4 studies was designed as a non-inferiority study. A non-inferiority study is basically designed to suggest that it's not a statistical difference between the 2, that one's better or not. It's that there's really one is not inferior in the outcomes. Although there are inconsistencies in these 4 studies between sample size, how or when the NMES was used, and the outcomes measured, there were still several takeaway points. So the takeaway points from these 4 randomized controlled trials that were in follow-up or in somewhat rebuttal to that initial Cochrane review that used 2 studies, 2 of the 4 studies suggested, 2 of the 4 studies that showed positive benefit, NMES was initiated on the 2nd postoperative day. 1 of the 4 studies showing no benefit NMES was not initiated until the 4th week postoperatively. So the difference between NMES and the no NMES groups seemed to be most marked in the 1 to 2 week at 1 to 2 months between those that received NMES and those that did not. So these 4 reviews collectively supports the assertion that NMES is most helpful when the activation deficits are the most pronounced. And that goes back to those neural factors. When the patient is unable to volitionally activate motor units, NMES has an advantage. And conversely, the benefits of NMES decrease almost exponentially if it's delayed or if we wait until the deficits are considered persistent. And it's very common in my area of the United States to not see see a physician refer a patient for NMES until they've already been at their 6-week postoperative checkup and are showing quad deactivation, an extensor lag, or any sort, however it's described. At that point, we're well beyond, we're kind of at that optimal window and beyond 4 weeks for the most premium optimal window for the use of NMES. Now here's an area of NMES that a lot of people are not familiar with. A 2013 Cochrane review looked at the use of NMES in patients with advanced disease. There were 11 clinical trials used here, and the comparison was NMES versus no exercise or placebo NMES in patients with COPD, chronic heart failure, or thoracic cancer. The NMES was shown to improve quadriceps strength, the 6-minute walk test, and incremental and endurance shuttle walk tests. And the suggestions, the conclusion of this Cochrane review suggested that NMES appears as effective means for improving muscle strength in patients, adult patients coming from these chronically ill patients. And it seems to be due to, as a result of addressing the underlying loss in strength that coexists with these pathologies. So to summarize the literature, the recent literature on NMES, when used properly, there's more benefit. I mean, there's more evidence to support the use of NMES than there is to refute it. But the people that want to refute it will latch on to a few poorly constructed conclusions from poorly constructed studies. NMES should be used early, an optimal window of 1 to 4 weeks, maybe reaching out to 1 to 6 weeks. In this period when recruitment is the primary limiting factor. And it appears also that NMES may offer subjective and objective benefits sooner by perhaps some of those secondary mechanisms. So a patient becoming ambulatory sooner, or not requiring crutches, or maybe being able to advance to a treadmill if that's the case. These are some of the data that suggests patients receiving NMES improve their quality of life sooner than populations not receiving NMES, despite the fact that at 1 and 2 years, there does not to be 1 and 2 years post-injury or post-operatively, there's not substantial evidence to suggest that NMES was better than no NMES that far out. It's in the more subacute time. All right, so we have evidence for why we should use NMES. Let's look at some of the recent considerations and evidence for why NMES works. So this will kind of start on a foundation that I'm assuming and confident that you're familiar with, but we'll put some new understanding to it. So let's consider volitional strength training first. We know that with volitional strength training, there's a time course to the adaptations in strength, such that in the initial 6-week period, we see relatively rapid improvements in strength, which then tend to decline thereafter. We know that the underlying factors here are both neural and intrinsic or peripheral from hypertrophy. But we know that hypertrophic response is delayed. And so it's clearly known that it is the underlying neural adaptations that occur within that 6 weeks that results in the significant and rapid increase in strength. This rapid 6-week increase in strength is largely mediated by changes in motor unit recruitment. We see increase in the frequency, size, numbers of motor units recruited, and we see a synchronization of motor units. Now, not ironically, but say NMES also does all 4 of those things when applied to skeletal muscle. Now, from a practical basis, NMES should be considered an applied stimulus. It's an applied training stimulus used to offer an appropriate training dose to a patient that lacks sufficient volitional activation. NMES engages the neurophysiologic mechanisms, both intrinsic and extrinsic, that lead to an increase in strength. And I emphasize it is when the patient cannot do this. When the patient can do this, the efficacy for NMES is greatly reduced and is essentially not warranted. But it is that period, and again in that window of roughly 4 to 6 weeks, when the activation deficits are precipitating the intrinsic or peripheral changes at the level of the skeletal muscle, that NMES is most warranted. So I lived in Louisiana, in the United States, for a long time, and there's a reference to the holy trinity of Cajun cooking: onion, bell pepper, and celery. So I kind of adopted this theory to electrical stimulation, and I call it the holy trinity of electrotherapy. And this is the way I teach this. If you know the holy trinity of electrotherapy and you understand some numbers, some parameter numbers to go with these 3 parameters, you are going to be a lot more successful than a lot of people that don't know the holy trinity. So let me offer some evidence for selections here, because there's always discussion about these parameters, what's best. And I'll keep this really straightforward. Frequency. We know clearly that there is a force-frequency relationship. and that between 50 and 80 hertz or 50 and 80 pulses per second or whatever parameter you want, and I won't split hairs with it right now, but whatever parameter you like between 50 and 80 seems to be peak for eliciting force in skeletal muscle. Beyond 80, there's not an appreciable increase in force to warrant the sooner fatigue that will be induced by the higher frequency. And below the 50 hertz or 50 pulses per second, we do not optimally contract that skeletal muscle for the purposes of strength training or developing strength. Pulse duration. We know now from a lot of studies, some of my own in the last few years, that the longer the pulse duration, the more force we can elicit. Now keep in mind that this holy trinity is kind of like the Olympic circles as well. They're kind of all intertwined. You adjust one, you adjust another, and you get different effects. The longer duration of a pulse or a phase duration elicits greater force. It's been shown in a lot of studies recently. Typically on a neuromuscular electrical stimulator, we'll see pulse duration ranges available between 200 and 1,000 microseconds. And I'm not familiar with every device that you have in Canada, but I know took a tour of the facilities. I saw several Chattanooga units from Tennessee in the United States. I'm very familiar with those. So I know those run in that range. For comparison, Russian, which probably everyone and their mother is familiar with, has a cycle duration, or if I can refer to it as a pulse duration so that we're talking apples and apples. Russian uses a 400 microsecond duration. FYI, or for your information or comparison, high volt pulse current is 100 microseconds, which is one of the reasons when I get questions and people are using high volt for NMES, I talk them out of it quickly because it's only 100 microseconds. And so what do you need to do if you've got 100 microseconds? It's very, very short. What do you have to do in order to get a better contraction? Yeah, so you got to crank up the amplitude generally. And then what do you think the patient tolerance is with that? Right, so the laughter in the crowd, right? So that's not going to lead to good efficacy. So despite the fact that high volt can elicit a muscle contraction, doesn't mean it's good for it. I can eat Big Macs every day, but it's not good for me. I'll come back, or I'll come back. No, I'm not leaving, but I'll get to it later. That I'll show you some data from our studies recently where we've used 1,000 microseconds and what we've done with that. So that's extremely long. That's eternity. That's a millisecond. In electrophysiology, a millisecond is eternity. But the bottom line on this graphic here, as you can see, if we start widening out the pulse duration, essentially what happens is that's greater energy. So if you see that each one of those pulses maintains the same amplitude, if we increase the pulse duration of it, we're delivering more energy to that patient with each phase or each pulse. More energy, more force of the contraction up to a point. So here's this up to a point thing. Intensity or amplitude. Force is proportional to an intensity. It's up until that point where you've depolarized or recruited all the recruitable motor units within that region of the electrical field. Once you've recruited them all, that's your peak force. This relies on the overload principle, which we know underlies adaptation. We must overload the capacity of the skeletal muscle in order to elicit adaptation. So as intense as able. I'm going to answer how intense in a moment. If you put an NMES on a patient and you get a weak, wormy, squirmy contraction, and they're begging out, tapping out, saying that's enough, your NMES is not likely to be effective. Now that may be the case on that situation, maybe in the first initial exposure. Maybe we need to work with that patient to convince them, educate them why they need a higher intensity to get a better contraction. But if all you can get is a wormy, squirmy contraction, ask yourself if you would get stronger doing that when you go to the gym. It's just not a proper stimulus. It will not overload. All right. So how much amplitude is enough? I like to refer to it like I do in pharmaceuticals or pharmacology. We need to refer to it as a dosage. We talk about dosage in other areas, laser, diathermy, ultrasound. We don't really talk about dosage in NMES. So this has been something that I've been campaigning, I guess, about. We need to quantify what is the dosage that we use. I know I can only speak for my countrymen and their poor lack of documentation, but I'll go to pick up a patient's chart and they'll say, NMES, 20 minutes. Was that just one contraction for 20 minutes or what? So I'm not really sure what that means, and I'm willing to bet money on the table that they use the default settings on the machine. So I probably have a good chance of repeating what they did just by not pushing any other button. All right, so training intensity, dosage. How do we address this? I'm going to recommend, a lot of us that are experienced, which means older, we've made our mistakes already. A lot of us are suggesting use a training intensity of 70% of the uninvolved side, but we'll see some other studies, I'd like to say several, but few actually document their dosage this way. We're going to look at some using 40 or 60%. That's 40 or 60% or 70% of the maximal voluntary isometric force of the uninvolved side. We have to assume that there is an uninvolved side, but I am for the sake of today's discussion. So the method to do this is really straightforward. You measure the maximal voluntary isometric force on the uninvolved side. Do it however you like. Sit a person down in a device such as on the screen. Determine what their max is on the uninvolved side. Then set up the patient for the appropriate neuromuscular electrical stimulation using the parameters and waveforms of your choice that I'm going to tell you what to use later. And turn up the intensity until you get a specific target of force for that involved side. A few weeks later, a week later, 2 weeks later, retest. This is really no different than in traditional design of strength training programs or when identifying appropriate heart rates or VO2 levels, target levels in a cardiorespiratory program. So this is how I do it. I shot this video in the clinic on the way, last week before I came. Here is a friend of mine that's supposed to move, and there we go. All right, so he's going to take his right uninvolved side. I've just got him on a weight stack over there, real simple. I could get fancy with the CanCom Lido or Biodex, but this works really well because I can just bend over real quickly and keep sticking a new weight in. It doesn't matter to me that that's 10 mountains at a time. But I keep going, and I get to a weight, and I say, okay, go. And so I go back and say, okay, we're near as one RM. So for sake of mathematics, you don't need to pull your phones out for it. And my students pull out calculator on the phone all the time when I have them do 10 times 10. I'm sure you guys have got that. But I just pick on my students because they pick on me. Right. So now I've instrumented my subject here. I've got the device, I've got my neurostimulator, and I'm going to turn this up. I've set that weight stack now at, say, 70 pounds because his max was 100 on the other side. And what I do is I turn that up just until we come back down. So we'll assume that his max on the uninvolved side was 100 pounds. I want him to train at 70% of that. So I pin in the weight at 70 pounds. If I explained that well enough, okay? All right, so far. All right, set him up, got my electrodes placed, whatever. And then I've selected my waveform, I turn it up, I get to the amplitude that just causes that weight stack to move. You see the little yellow pin over there? And now that is what I will refer to as my dosage. So I know the parameters. I've got a waveform to document, a pulse duration, I've got a frequency, and I just cranked up the big wheel, I call it, on the amplitude dial, and I record an amplitude of 65 milliamps, or whatever it might have been for that particular patient. Kind of, letting that one roll. That's my dosage for that session. That's my dosage probably for that week. I'm going to retest the following week or the week after and determine, again, his MVIF on the other side probably won't change a whole lot, but now I can adjust my intensity if I so choose. Did I explain that well enough? It's a very simple technique. It only takes a few minutes. And if you can in your clinic, you could treat them right on that same device as long as it's not one, a popular device and another patient or client needs it. Very simple, very quantitative, very repeatable. Everybody in here could repeat that if I documented that for that session. Okay, let's talk about waveforms. The thing that people always ask me about. I get 2 or 3 emails a week. What about this? What about that? Right. So when you have a multi-waveform generator like this Vector Genesis, it can be overwhelming. When you whittle this down and you look at it and it suggests that there's probably, 3, 4 waveforms on there that you could use for muscle contraction. Let's take a look at it. All right, got to start with the king, right? Well, I'm gonna knock the king down a little bit. Everybody's heard of Russian current, I assume. And if you've taken modalities, you've heard of Russian current. It's burst modulated alternating current. That's all it is, BMAC, burst modulated alternating current. Let's have a little fun here for a moment. I can't assume, but I'd like to, everybody knows why it got its Russian name, but I want to tie it in to several other countries. It was named Russian because a Russian exercise physiology named Dr. Yakov Katz created, so to say, this characteristic waveform of alternating current. It received its international recognition in what is considered its debut right here in your country, the 1976 Montreal Olympics, Summer Olympics. Ironically, does anybody know who won the men's decathlon that year? Bruce Jenner. What's Bruce Jenner doing these days? Russian current stuck around for decades. It was the go-to form. Many, many devices were sold with Russian current until Professor Alex Ward at the University of La Trobe in Australia began to question Russian current, saying, well, it's good, it's fine, but is there better? Can we find something that's better than that? So he started playing around with another form of burst modulated alternating current, found that it was better, so I now refer to it as better Russian, and I'll give you some data and evidence on it. He created this waveform that was picked up by a company in Brazil who is the sole manufacturer of what is now known as ADCTEST current. We have Russian current, now we have ADCTEST current. So it was in Brazil that Dr. Draper and I had the opportunity to meet and do some teaching down there, along with Professor Ward. And so now, here in 2015, Dave and I are in Canada. And so I just like to suggest it's a small world, but Canada, you guys have played a big part in the world of NMES. So keep it up. Dennis, you're off to a good start with them. So I don't want to go too far with Russian current, but I want to point out its defining characteristics. It's burst modulated alternating current, sinusoidal shape. This is a fast food Russian current, conventional. This is the branded name. You can vary it a little bit, but the Yakov Katz version is a 2500 hertz carrier frequency bursted at 50 bursts per second. That's the frequency. That's the frequency that your motor nerve sees, 50. So right within that force frequency range, this is why Russian current works. As a cycle duration, or if you want to consider a pulse duration, I won't split hairs, but it's an alternating current, not pulse. But it has a duration of 400 microseconds, which is very sufficient for skeletal muscle or motor nerves. And it has this 10 millisecond burst interval with a 10 millisecond interburst interval. So 10 milliseconds on, 10 off. It's referred to sometimes as a Russian duty cycle or a relative duty cycle. But the way I explain it is when Russian current is on, it's on 50% of the time. So these are the three of the defining characteristics of why Russian current has worked for decades, while it still works. But I'm going to show you some better options. Another waveform, very, very common, symmetrical biphasic square. That's its shape. Anybody that's ever played with an Etch-a-Sketch as a kid, you can make these waveforms. My daughter's 4, she's making waveforms. We're going to name it something, I haven't figured it out yet. But symmetrical biphasic square. This is the most commonly used waveform on handheld stimulators for years. Still very, very common, handheld stimulators. Pulse duration, and the manufacturers usually make this between 2 and 600. Sometimes they just average it out and make a fixed duration of 400 microseconds. And it typically has a frequency range between 30 and 80. So you can clearly get within your 50 to 80 peak range for strength. There's 2 reasons this waveform works. I'm not saying it's bad. It's 2 reasons it works for NMES. Because of its rectangular square shape, it has a relatively instantaneous rate of rise. And when it is on at peak amplitude the entire time. So what this means is for the area under the curve, that slightly, I don't know if you want to call it darker, Mount Royal blue color, maybe I hope I'm close to being, but the color inside the square, because that is instantaneous rise and it stays at that peak the entire time, the area inside that phase is greater than if it were ramped up and down. And I want you to hold that thought in mind when we start talking about areas within the curve and what that means. And that parameter is phase charge, phase charge. Now, Chattanooga Company out of the United States took this symmetrical biphasic waveform back in the 80s, and based on some evidence that of using what's called an interphase or intra-pulse interval, they noted from paper from Bowman and Baker that they can get the same force output at 10% less amplitude. That was the initial impetus for this interphase interval. And so this is what the proprietary VMS waveform is. So if you watch Antiques Roadshow, you might see a VMS stimulator unit, or if you go into your Intellects, the Vector Genesis, a sub button under your electrical stimulation button, it usually oftentimes will have VMS. That's what this is. Right. More recently, this idea of the use of the interphase interval was substantiated by Laufer when, I believe she, I have to, looked at this and used a variety of different interphase intervals and noted that on the far right of that screen, interphase intervals of 150, 250 microseconds versus no interphase interval or 10, 50. The higher interphase intervals elicited greater muscle force than the use of lesser or no interphase intervals. So you don't have, the devices that I've seen here, you don't have an option for changing that interphase interval, but it substantiates the use of a VMS waveform. Not that I'm advertising for Chattanooga, but it is a waveform that offers you that interphase interval, which the strict symmetrical biphasic does not. So VMS was pretty good. So they came along with a new waveform, not relatively new anymore. I've said that long enough that I can't say that anymore. A waveform called VMS burst. I refer to this, it's burst modulated biphasic pulsed current. What this is a combo meal. This is a hybrid. This is combining the bursting of Russian and the shape and the interphase interval that we see with VMS. So it's taking key features of two things and combining them. I don't know if the Intellect in the lab has this. I use the Genesis a lot more. But if you have this VMS burst, what it is it's three symmetrical biphasic pulses elicited together in a burst. It uses a fixed, meaning unchangeable, fixed interphase interval of 100 microseconds, which is the proprietary creation of Chattanooga. And it bursts it at a frequency that you set it at. So conventional Russian uses a burst frequency of 50. If you so choose, you can use 50, 60, 70, 80. If your purposes are for increasing strength, shoot between 50 and 80. You set it. It has a variable pulse duration. You actually, on the Chattanooga units, end up setting phase duration. So you have to be a little careful. If you set 400 microsecond phase duration, you've got to double that for the biphasic pulse. So you can select a longer phase duration, which the evidence supports, and I'm going to continue to show you some evidence for these waveforms. So that then kind of leads to this ALSI current, which I refer to as better Russian or burst modulated alternating current. Well, that's also what Russian is, but this is modified Russian as well. I'm not sure that this is available in Canada yet. They recently came into the United States about 1.5 years ago and starting to make some impact there. Here's what ALSI current is. Keep in mind what Russian is, but I've also given you kind of the contrasting data. ALSI current uses a 1 kilohertz or a 1,000 hertz AC carrier frequency, which is different than rushing, which was 2,500. ALC current uses a 2 millisecond burst duration, sometimes even 4, but characteristically 2, in contrast to the 10 millisecond burst duration of rushing. And ALC uses a 10% duty cycle versus the 50% of rushing. So I'll point it out here, and I'm going to elucidate on this later. The 2,500 hertz carrier frequency of rushing, the frequency, that yields the 400 microsecond cycle duration. One cycle of AC, 400 microseconds for rushing. With ALC having a 1,000 hertz carrier frequency, the inverse of that, 1 over 1,000, is 1,000 microseconds. So decreasing the frequency elongates that sine wave, and it's going to result in, I'm going to show you, it's going to result in greater force. So those are all waveforms that are, with the exception of ALC for a while until it comes to Canada, that you have at your disposal. So I give you this information for clinical decision making. What are you going to choose and what's best? All right, so which one? Let's look at rushing and ALC. So Alex Ward, several papers by Alex Ward. If you look his name up, there's some excellent papers. He looked at muscle force production, or torque. He looked at torque and using a variety of different carrier frequencies and duty cycles. And he showed that in the blue arrow at the top, a 1 kilohertz or 1,000 hertz carrier frequency yielded significantly greater muscle force than the 2.5 kilohertz or the 2.5 kilo or 2,500 hertz duty cycle. And that at the blue arrow there represents a 10, or combined, they come up 10 or 12.5% duty cycle. That yielded significantly greater force than the 50% duty cycle of rushing. And this is, again, with a lesser carrier frequency, lesser burst duration, and a lesser duty cycle. So what about this concept of the effect on shape? I told you about the Etch-a-Sketch, and I'm assuming that's a universal toy, correct? All right, thank you. Anymore, I don't assume a whole lot. But you play with Etch-a-Sketch and you start playing around. If you ever took, took geometry and trig and everything and painfully remember that, you can easily remember areas under the curve. Well, I went back and looked at some engineering data and some studies, and it was a really nice paper back from 1980 from Bankoff, who looked at the different shapes. And he looked at an alternating waveform. Now, if you consider the X and Y variables, you got Etch-a-Sketch with you, right? Going X and Y, going left and right. So if you made a sine wave like that, and then you superimposed over it a square, or a rectangle for that matter, that has the same duration and the same amplitude, will look something like that. And now consider area under the curve. So for the same X and Y, the same duration and the same amplitude, looks the same on paper. I've got the same duration, I've got the same amplitude, but the shape now makes a big impact. There's approximately one third greater charge in that square or rectangular form over the sinusoidal form. If I can deliver 1/3 more stimulus to the patient, it makes sense that we get a greater elicitation of force. So this concept of greater torque with greater phase charge was substantiated by Wayne Scott in the United States, looking at a variety of phase charges. So making the area under the curve greater, getting more force. So in 2012, we published a paper that looked at it this way. We said, okay, rushing's good. What about this hybrid thing, that burst modulated biphasic pulsed current? The one that was kind of a hybrid of VMS and rushing. So we said, okay, let's keep the parameters that are common the same. So we use the same frequency, the same phase duration, and we use the same amplitude. Let's see how much force we get at 100 milliamps. But the dissimilarities were right here, and particularly right over there. We used a lesser carrier frequency, a lesser burst duration, a lesser duty cycle, and the key thing is we had that rectangular shape as opposed to sinusoidal. So we turn them up to 100 milliamps, record force, and what do we find? that burst modulated current yielded 63% of their maximal voluntary force. Russian elicited only 36%. If that's a training stimulus, or you go to the gym to work out and you use 63 pounds or 36 pounds, you know which one's going to make you stronger, sooner, better, faster, quicker, smarter, right? That's the evidence behind why we choose certain waveforms over another, is we get a greater training stimulus. So then combining some of this evidence, when we look at Ward's papers and studies that suggest that lesser carrier frequency, lesser burst duration, et cetera, yields greater force. We look at our work, we look at Bankhoff suggesting that shape makes a difference, and we look at Wayne Scott's works that suggest phase charge is important. We came along then and more recently looked at something rather simplistic. We just took one of the Chattanooga units and said, okay, let's just simply change the phase duration. By doing so, we can effectively change the phase charge. So we set a 400 microsecond phase duration, and we used a 120 microsecond phase duration. And the reason we picked that is because we couldn't precisely get what we wanted to make a 2500 hertz carrier frequency. Just was a limitation of the parameters available to us. But we tried to approximate it to get to 2500 hertz. So we had a longer pulse duration that was due to a lesser carrier frequency, much like Ward looked at. And we looked at a higher carrier frequency, which meant that the sine waves were coming more frequently, which meant that the phase duration was shorter. And so what did we find here? We found what I sometimes refer to as the white whale. We found near 100% elicitation, 100% of the maximal voluntary force with the use of that burst modulated biphasic pulse current using a lesser carrier frequency versus 40% of the maximal voluntary isometric force. And I contrast this into sort of a global survey of the data on NMES, and typically studies using NMES are eliciting forces in the range of 30 to 60% of the maximal voluntary isometric. So to be able to train at near 100% or peak has been somewhat elusive to this point. And so we've been doing this, and we've got plenty of other people collecting data and seeing the same thing, simply using a proprietary waveform that's available to many people just by modifying, go in the edit button. The edit button is your friend, I teach everybody. So wrapping this up, where are we now? Evidence for NMES is robust. It's probably as robust as it ever has been. New evidence for waveform parameters, waveform shape, the selection of these, it continues. We're getting more and more new data out all the time. With that, however, quality training studies are relatively sparse. We have some decent ones from select populations. We have these newer ones from the patients with advanced disease, or there's still a relative sparsity of quality training studies. And another limiting factor that we were talking about since we've arrived is this bias against electrophysical agents, which seems to be sort of the precedent for how we got to the idea of this conference in the first place. And that if there's a bias against electrophysical agents, this may limit its use and therefore limit its extendability out to the patients that need it. So what conclusions can we say? Neuromuscular electrical stimulation is a tool. It needs to be used selectively, not randomly. It needs to be used on patients who have appropriately been identified as having difficulty with volitional recruitment. And it needs to be used within a suitable time frame. So if you have to campaign, recruit, or advertise, or whatever you need to do to convince, in our case, referral sources to be able to get those patients or advise the physician on how to recognize a patient that needs it, so be it. But get those patients on it sooner. We now know, too, that the benefit of NMES seems to exist or extend beyond the athlete, largely coming from the studies coming from those patients with advanced disease. And right now, we probably have the best evidence ever to support the selections of parameters and waveforms. So I encourage you to use it. I'm going to wrap up there with, again, a final thanks to our sponsors, and I'll be happy to entertain questions now or later, whichever it may come, and after the sessions as well. Thank you very much for your time.
So just saying aware of the time. We have 5 minutes to entertain questions. Mark's going to facilitate this, and I'll get the next speaker ready. So I'll hand it over to Mark.
All right. So thank you very much. That was great. And I know we have a lot of alumni here, and I'm wondering if I've taught anybody outside of Larry back in the 90s. Because one of the things that and so while you're thinking about your questions, one of the things that I noticed, and I told you the story earlier, but I went on sabbatical a couple of years ago, and I came back, and when I came back, I was preparing to teach the modalities course again. I looked for new and great things, and so his work is some of the new and great stuff that I think I've discovered as I was doing research. And one of the things that I taught back in the 90s was that waveform didn't matter. So if you go back to the Nielsen and Courier books back in the 90s, they'll say that waveform didn't matter. And I think it's a really, and so I don't know if I've taught that to anybody at any point, but I want to take it back. I know I didn't teach it last year to the folks that were in the program because I've been using his new research, but waveform does matter. And I think that's one of the key messages in your story today. So I'll stop talking. Any questions from the audience that are here, and how about online? So people that are online, feel free to take your questions in if you have any. Yeah, Tim.
Sorry, I made a comment about a battery-powered MES versus, one that's connected to modalities. Is there a difference clinically if you use the handheld versus the?
Yes. Should I repeat the question?
Yeah. Yes, please.
So I made a comment earlier that one of the limitations in studies is the use of battery-powered devices. And until a few years ago, and I do not work for any company, until a few years ago, the handheld devices had been shown to be inferior, specifically in eliciting force compared to line-powered plug-in units. Then came along the EMPI unit called the 300 PV. And this 300 PV, don't write it down because it doesn't exist anymore. Fitzgerald et al., I can't recall the year, Fitzgerald et al., I believe it was the one who put out the paper that showed that for the first time ever, a handheld unit was comparable to, not different than the line-powered units. Now, that uses a symmetrical biphasic square. Off the top of my head, I don't remember what it was that they used as their waveform for the plug-in unit, but the guts, if you will, of the 300 PV are now part of the MP continuum. I do not work for them. I'm not advertising. I'm telling you what's available to you. So the 300, the continuum now has the guts of the 300 PV, and I can't say so confidently that the MP Phoenix, which is a garnet-wrapped embedded electrode handheld battery-powered unit, if that has the same guts or not. Excellent question.
Yeah, so on that note, one of the reasons why we brought the machines here today is based on the research that I've done, we've been buying new machines for teaching students. And so, and that was one of my questions was, you have no bias towards Chattanooga. It just so happens that they're the ones that create the VMS and the VMS burst that you advocate for and the ones that you're doing research on.
I'm not paid by any of them. I just use what's there. I have a friend who's a biomedical engineer. Radio Shack is one of our favorite stores. We go and we make things. He makes things, and I shock people with them. Or he takes apart a vectorgenesis, or takes apart a device and allows us to manipulate the variables, because I don't exist in a major research institution that pays us to do that per se. But sometimes we create our own stimulators to see what the effect would be, and then we say, well, what's the closest thing to this on the market? So years ago, when I started identifying this VMS burst, I said, well, that sounds pretty similar to what this biomedical engineer of mine was doing. Let's try it out.
Perfect. And Larry, which units have it and which ones don't? For those of you, before you go any further, that's Larry Mack, I'm sure. Larry is the primary director with MedWest. But Larry, what are the units that have the VMS first?
Just currently the intellectual dynamics.
Do you get the Genesis here?
That's the comparison to the US.
Okay. So good. So knowledge for me to take home. Good. So I want to just emphasize that these are things that in the clinic we just started asking, and Alex Ward, was one of those guys that kind of on the same wavelength. We just started always asking, so what is there better? Is there better? And until we find perfect, which we never will, we keep asking better. So it's just use clinical inquiry to feed your research.
Other questions?
Yeah.
You said NMES is only indicated for people that have neural deficits post-surgery. Clinically, how do we test the neural difference between neural deficit and just structural deficit or muscle fiber? Okay, so I suggested that it's more indicated. I want to retract the word only, but actually I don't like those extremes. More indicated for patients with neural deficit. And what I mean by that is recruitment issues. And so clinically, I'm not going to do EMG on them to determine that. But I might look at it for extensor lag, a comparative sign. Are they able to generate as robust a quadricep contraction as the other side? Are they able to isometric knee extension, whatever may be indicated for that patient and their post-operative or post-injury considerations. If it seems to be recruitment, if it's acute post-operatively, it's not intrinsic yet. They haven't yet had that significant enough atrophy or fiber loss to account for that as much as it would be activation deficits. Did I explain that well? Yeah. Okay. Thank you for the question.
Maybe along, yeah, go ahead.
Sorry, okay, one more thing. So if I have a symmetrical biphasic square waveform from a patient, and I set a 1 second ramp for comfort, if I extend that to 3 seconds, being more comfortable, is that going to change my waveform? Sinusoidal waveform? I
don't know, because you need to pull out the manual and see, and this is why, because we don't know. And the only way you'll know this is to look at the manufacturer. So if you select, let's say here's your 3 seconds, if that's right. But you also decide to put in a 1 second ramp. What we don't know, and you have to look at if that 1 second ramp is part of the 3 seconds or not. It may be or it may not be. You have to look at the wave. So if it is, if it's not, then you actually have additional energy delivered to that patient, same as if you do a fall. And if it is part of it, which a lot of people do, they want a 10-second contraction, but they do a 2 second rise and fall. That might mean they're really only at peak for 60%, 6 out of 10 in this case, 60% of the time. And these are considerations that are easily overlooked. But great question. Pull open the manual and see what they got.
I'm going to do a follow-up to his question, if you don't mind, and then you guys can think about your question. So you use the time frame of 6 weeks as that kind of golden time frame that in the first 6 weeks post-surgery or post-acute injury that you'll get the best effects with muscle stim. So further along his question though, what happens if you get somebody that has patellofemoral pain and they're not firing their VMO for whatever reason, because of the pain we assume? Would you put them into that category even though they've had patellofemoral syndrome for a year? Would you if they're not able to fire that muscle appropriately and timing-wise, would you still put them into that 6 week period?
So good question. First of all, I'll say the 6 weeks is really kind of what evidence is telling us. 4 weeks may be better. And in the example of the patient with the chronic patellofemoral mechanism dysfunction and maybe pain, I'm looking at that as that's a different scenario, because that's not post-operatively or post-injury. That's a different scenario. We're going to have a different mechanism for the loss in strength. It may not really be the predominance of neural that we depict from the graphic that I was identifying earlier when we get loss of volitional recruitment following the injury or post-operatively when we have edema, neuroinhibition, etc. in this case. So in that particular patient, the use of neuromuscular electrical stimulation may become what might be called neuromuscular re-ed. So active contractions of VMO assisted by the electrical stimulation and maybe not driving for the peak forces that we're trying to get under what I'll refer to as just straightforward traditional NMES when we're trying to drive stimulus to get the greatest force possible. Did I explain that? Okay, that's a good question though. Good to know that.
Maybe just one more question, and we'll take a break. Dennis?
Yeah.
Okay.
Okay, well, very good. Well, thank you, Jim, for a great presentation. We'll take a 5-minute break. I'll start my clock, as I normally do. 5-minute break. We'll ring the bell at 4, so we'll see you back in 4 minutes, hopefully. Thank you. Okay, welcome back from the break. Again, I'd like to thank Jim for such a great presentation. Wonderful knowledge he has given to us. Moving into the next part of the event, I'm just going to hand it over to Mark.
So one quick note about questions. I know some people had some individual questions, but remember at the end of the entire, all three speakers, we're going to have a 45-minute roundtable discussion. So that'll be your opportunity, hopefully, to ask more questions. Yes, we are having questions at the end of each speaker, but if we run out of time, that's okay. We have more later. So, so we have a draw to do at the end of each speaker and the beginning of the next session. And so I'm going to have people that are going to come up and help me. The person that's here, most people may know, some people may not. Some of the young bucks probably don't know. But this is Dexter Nelson. And so it's funny because the students that are here this year said, oh, that's Dexter, because I've mentioned his name a few times. So just for fun, I'm curious, people that are out in the audience, maybe people that are online, we have Dexterisms. Does anybody have a good Dexterism to share? Oh, okay, here we
Should
go.
they be censored?
What?
Censored, Dexter?
Yeah, no.
Fair enough, doesn't a phone booth.
Fair enough, doesn't a phone booth. Any other?
That is on it.
Any other good Dexterisms? Make chicken salad out of chicken. Beep. Anyways, Dexter, as you may know, is a former professor here, instructor here. He also won the Lifetime Distinguished Award for Alumni. He came here a long time ago as I think it was a university transfer student, right? Yes. Yeah. And so started his career actually at Mount Royal, ended up going to a number of other places. But a number of years ago, a friend of mine and Dexter's thought, you know what, he's given so much to our institution, and he's come a long way since his university transfer days. He's since retired, of course, but we nominated him for this wonderful award, and that's just one of the alumni awards. And so I'm here to plug the Alumni Association a little bit with Mount Royal University. So one of the reasons why we're doing this is try to get more people engaged, come back to the program. Dexter's one of those. We've also have some other people that I'll introduce later, but there are a number of different awards that we can apply for people. So Dexter's going to help us pick a name out of a hat, and then we have a grab bag. Somebody can come up here and grab it. Dexter, who is it?
Jennifer Dunn.
Jennifer Dunn, come on up here. Sorry for people that are virtually there, but so Jennifer, hopefully I didn't give it away. You have to close your eyes. Well, let's do it in front of the camera. Are we on camera?
Yeah.
Here we go. Close your eyes. Put your hand in. Reach in deep and grab a special gift. Yay!
Wait.
Dennis is a funny guy.
No, I'm not that funny. Come on down. Come
No,
on
come
back down.
down.
Come on back down.
You really have to.
You get another gift.
Larry from MedWest actually donated something a little nicer than this t-shirt. So there you go. Congratulations.
Congratulations.
All right.
Thank you, Mark. So to introduce the next speaker, I'll bring Brita up.
So our next speaker comes to us from Eastern Canada, all the way from the province of Quebec. His name is Dr. Alan Belanger, and he was a full professor at the Department of Rehabilitation in the Faculty of Medicine at Laval University. So he too has worn many hats throughout his career, and he currently is a consultant for physiometrics. Along the way, he's obtained his Master's of Kinesiology at Simon Fraser University and his PhD at McMaster University. And most importantly, again, he's currently retired, but most importantly, he is the author of this beautiful textbook. So again, you can never have too many modalities in textbooks. So I encourage you to pick this one up as well. It's called Therapeutic Electrophysical Agents. Please, let's welcome Dr. Alan Belanger.
Share screen. Good afternoon, bon après-midi. All of you are here today to find out what's new, what's exciting about therapeutic modalities, right? And you are also here to optimize your practice through evidence. Okay, now I have a warning for you. The presentation I'm about to give is shocking. Okay, so your attention is advised. Before I begin, I want you to experience what a shock wave is. And before I show you this video, I want you to keep in mind that the speed of sound is roughly 340 meters per second. Keep that in mind because after the video, I have a question for you. So, watch this video. It's coming. All right. Now my question for you. Whoops. Maybe I'll go back up. A question for you. Can you tell me at which distance the camera was from the site of explosion?
1 mile.
1 mile. How do you know that?
Pretty round number, it's around about 4 or 5 seconds.
Wonderful. If you pay attention, you notice, many of you, that it took about 6 seconds from the time we saw the beginning of the explosion by the time we heard the sonic boom. So yeah, if you multiplied 6 seconds by 340 meters, you end up roughly at 2,000 meters. Now, all of you that have a good answer here will remain seated for the rest of my presentation. Now, those that did not get the answer, well, Dr. Valdez told me, I'm sorry, they will have a second chance, but if they fail, then they're in trouble. So here's your second chance. Now, you may think that this is a quiet day at the beach. Is it? Same thing. If you noticed, by the time the jet broke the speed of sound, because it did, you saw the cone at the back. And by the time you heard the, so I'm going to get out of here. But by the time you heard the sonic boom, it took about 3 seconds. So if you were to multiply 3 by 340, you get about 1,000 meters. So the people at the beach were about that distance. Well, shock wave is all about the speed of sound. And the speed of sound in air is roughly at 340. It is 4 times faster in water. And here you have a visual display of this plane breaking the speed of sound, shown here as a vapor cone behind the plane. Okay. Over the next 40 minutes or so, I'm going to be presenting you a relatively new mechanical agent in the field of electrophysical agents. And I will show you these things. I will show you that, yeah, it is a new one. It is roughly 15 years old. Okay? The evidence show, because it's based on evidence, that it can induce or generate promising therapeutic results. And contrary to other types of therapies, shock wave therapy is non-invasive and this is crucial for us in the field of rehab, this is the alternative we bring to the table. It is relatively low cost. Now, I'm not talking of $200 here. You will not find a shock device for $200, not even for $2,000. We're talking roughly $10,000, $15,000 for that. But this is cheap in comparison to what is there right now, and you will see more of that at the end of my presentation. And I will show you that this form of therapy is perhaps the best alternative we have to surgery for the management of something that all of you are dealing with in your practice, that is the management of chronic tendinopathies. And I will illustrate a case later. I will put it clinically for you by using a case of chronic tennis elbow. All right. Now, to do that, I will be presenting on those different topics. I will be speaking about the biophysics. This will be an overview. Talk about the physiological therapeutics effect, talk about the dosimetry, the application, talk about the research-based evidence, because we know in our field, it seems like every year or two, there's a new device, a new type of things, and it's pushed by several companies. Marketing is fantastic. Ask yourself all the time, where is the evidence? If you do that, you're on a good path to practice with a lot of solid foundation. And I will end my presentation with this case of chronic tendinopathies using lateral epicondylitis. What's a shock wave? A shock wave can be simply defined as a very, very brief, very, very high amplitude, acoustic or pressure wave. Now, when I talk acoustic pressure wave, some of you says, well, no big deal. It must be another type of ultrasound. Is it? What's the difference between the ultrasound that all of you know and the application of shockwave therapy? Let's have a look. Here I contrasted for you, based on 4 parameters, the difference between a shock wave and an ultrasound wave. Quickly, if you look at them, you can see the difference. I'll speak briefly to that. Peak pressure, we're talking of an acoustic, we're talking of a wave that will create pressure in the tissue. And our basic ultrasound does that, but compare the pressure. Look at the ratio. It's almost 2,000 times stronger, a shock wave. Look at the waveform. A shock wave, and you will see a picture of that, is a biphasic asymmetrical wave. Our ultrasound, of course, it's biphasic symmetrical. It's sinusoidal type of form. Frequency. Shockwave therapy is delivered at a very, very low frequency, rarely exceeding 100 hertz. In comparison to our 2 well-known ultrasound devices that will generate ultrasound waves at either 1 meg or 3 meg. And finally, the effect. Shockwave is pure, 100% mechanical effect in the tissue. Ultrasound. Well, I read the literature, and for me, you may disagree with me, but 99% of the effect of ultrasound is thermal. This little mechanical effect that we attribute to ultrasound, I have yet to read a solid paper on it. So for me, when I use an ultrasound, it is above all for its fantastic thermal effect. Okay, when you deal shockwave, you will face this in the literature. You will have the choice between a focused shockwave or a radial shockwave. Well, the term says it. And by the way, ESWT stands for extracorporeal shockwave therapy. The F stands for focus, R for radial. You will see the difference between the two. And at the end of this presentation, I will answer a question. Which one is best? Should you buy, should you use more of a radial shockwave device or a focused one? I will answer this question. For the time being, briefly, here is what you have. To generate a shockwave, the industry used 3 different mechanical principles, I would say, or generators. And these are the electrohydraulic, electromagnetic, and piezoelectric generators for focused shockwave versus the ballistic for the radial. For the sake of time, I will not describe these three here for focus. Just keep in mind that electrohydraulic, well, we spark two electrodes in water. They generate shock wave, they are reflected and focused. The term focused, the beam is focused, converge towards the target tissue. Electromagnetic, this time we use a very high electromagnetic current that will vibrate a membrane, all this in water, and this will be reflected back and will create a focused shock wave. And piezoelectric, well, these you have here hundreds, thousands of those piezoelectric transducers that we know about because they are the basis of our ultrasound, right? But here they will vibrate at a given frequency and will generate shock wave that will be again focused. The radio, let me tell you more about it. It's based on the ballistic. Yeah, there's another mechanism, but I will not speak to it today. Ballistic generator, what do we have here? Here we have an end piece. This is your piece that you will be treating with. It looks like a gun, but keep in mind that the structure is this. You have a projectile there in red that will be moving in a cylinder and will come at the end and make an impact on a steel surface. And this will then create the shock wave. In other words, what I'm saying here is that through compressed air, this compressed air will accelerate this bullet in the cylinder. It will be accelerated at a very high speed, will hit this, and then the radial shock wave will be emitted. Here we're talking of a transfer of kinetic energy. You know what kinetic energy? It's half time the mass of this projectile multiplied by the speed, the square speed to which it is flowing. And this kinetic energy will be transformed into a impact energy when it hits the surface, the steel surface. And then when that happens, this impact energy will become a short wave. And this short wave will penetrate the tissue for the purpose of treating. Now here's the contrast of a focused versus a radial shock wave. Okay? And there's four parameters there. Keep in mind those. P plus, that's the pressure, the amplitude of the wave. P minus is the tensile force. We're not dealing with this because it's very small. The focus is on the pressure wave that will create what we want to create. The second parameter is the pulse duration, the rise time, and there you go. Now, if you quickly look, you can see the difference is that a focused shock wave generates much more energy, much more powerful shock wave as opposed to the other, and the wave is much briefer. And here I have a mistake. Correct milliseconds. That's in the book, and it should not be there. So we're dealing of microseconds. I'm sorry. Remove milliseconds and put microseconds. Let's later you watch this presentation. So this is what you have basically to differentiate them. Now a brief word about the history of shockwave. It started in Germany. It started in the late 1970s. And in 1985, the first patient in urology was treated using a lithotripter for lithotripsy. What is lithotripsy? It is the crushing of a kidney stone. The surgeon used to do it surgically. Now with shockwave, you don't have to. And here's the device. And I will quickly talk to it. Here you see FESWL. The L stands for lithotripsy type of wave. This is the most powerful shockwave on the market to use with humans. We in the rehab field use less powerful shockwave. And it is a focused shockwave. And what does it do? It is used to destroy something. So the effect is destructive. And to destruct the kidney stone, the principle is cavitation, unstable cavitation. Those bubbles will eventually explode. And when they explode at the surface of the kidney stone, they release tremendous amount of energy. I mean, in a gigapascals, but it lasts for only a fraction of a nanosecond. And those millions of bubbles crush the stone, and bingo, you get rid of it. So But in order to do that, the surgeon will have to make sure that he's shooting this shockwave at the right place. So the patient lies here. On top, you have an image guiding system. Could be fluoroscopy, could be ultrasound. Then the surgeon uses that to focus on where the kidney stone is. Underneath, you see the shockwave device. Then when everything is aligned, bingo, we go. And this, of course, hurts. So the patient is under local anesthesia. Now, a few years later, the German says, hey, that works well. Why not using this to treat soft tissue like tendons, perhaps wounds, perhaps bone? And they did some research. And they came up with a new term called orthotrypsy, the application of this in the field of musculoskeletal problems. They have provided us now with two types of wave, focused and radial, as you can see here. And here we have biological effect. We're after treating something, and I will come back to this. So therefore, there's no question we're not going to use unstable cavitation. We know that our basic ultrasound doesn't do that because its intensity is way too low in order to do that. So here we're going to have shock wave with fair amount of energy, but will be kept under the unstable cavitation effect. For the focus, because it's focused, you're going to need an image guiding system. The image guiding system, I will show you a device soon, it's ultrasound guided system. And analgesia, well, it's optimal, it's optional. It depends on your patient. Yes, it hurts a bit, but you can stand this. I mean, you don't have to receive analgesia before. As far as radial, well, it is the patient that will guide you. So you don't need an image guiding system. You will palpate, the patient will tell you where it hurts, and then you will dig it out and find out where the lesion is and how deep it is. And I'll come back to the concept of how deep it is because it's crucial to clinical decision-making later. Now, no analgesia is required. Everybody can stand this. It's not really comfortable as a treatment, but all of us can stand it. Here you have a picture of orthotrypters, 3 of them. They were made by Stores. Stores, yeah, it's a German company. And here you go. Here to the left, you have a radial shockwave therapy unit, roughly $10,000. Depends. Then here in the middle, you have the radial shockwave therapy, and on top, you have the ultrasound guiding system. And totally to the right, you have the radial underneath, you have the focus shockwave on top, and on top of all of that, you have the image guiding system. So you can see that the billing, the cost of this technology can add up because ultrasound guiding imaging system are not given. Okay, let's go back to this fundamental parameter. It is, after all, the amplitude of the shock wave that does the work, okay, because they are similar in terms of timeline. Here I contrasted lithotripsy, and look at the pressure of that wave, up to 1,200 bar or 120 megapascal. This is quite, this really shocks you, believe me. And if you were to measure it in terms of energy as opposed to pressure, the unit in this field is millijoule per millimeter square, and it's up to 3. This is the range of a lithotripter. We use orthotrypters, so we use focused and radial, and our pressure are lower, as you can see here. Okay? Now, there is something in the industry. When the wave is not focused, we appreciate the amplitude of the wave using only one unit, that is pressure and measure in bar. But if it's focused, you may have the option of recording your amplitude either by pressure in bar or millipascal, or in energy in terms of millijoules per millimeter square. Now, our friend at the bottom, ultrasound. Ultrasound, of course, is a sinusoidal wave, 1 meg, 3 meg, and very, very low pressure compared, 0.5 bar only. So it's not used, it's not a shock wave. And here the unit is measuring watt per centimeter square, its energy, as opposed to the energy measured for shock waves. All right. Now let's have a look quickly at the physiological and therapeutic effects of this. This is for both. Focused or radial, there's no difference. And the evidence what I'm going to talk about is strongly supported scientifically. There is a long list of papers published in peer-reviewed journals done in vitro, in vivo, in animals, and more recently on humans that supports what I'm going to tell you. It's not guruism, it's not something I pull out of my hat in the evening preparing a presentation, because this is something, you've been in the field, you know what I'm talking about. There's a lot of those magic therapy out there. What does it do if you were to expose a condition like a tennis elbow? Well, you will micro-traumatize. You will actually cause an injury. You use something to treat, but to treat, you're going to have to cause the injury, and I will tell you why you have to do that. In doing that, you will induce neovascularization. How do we know that? Well, scientists, they use all kinds of stuff. And they show that following the application of shock wave, you will have the release of growth factor, vascular growth factor, platelet-derived growth factor, all this needed to make the tissue heal. You will improve blood supply. You will have this nice proliferation and differentiation in cells. You will end up with an increased collagen synthesis. And at the end of the day, you've been using this to try to treat something that was stalled. The process is stalled, and you will see more about that in my clinical case presentation at the end. Now, this slide is crucial. This, you've been taught about that, and you will never, as long as you're a clinician and work with musculoskeletal injuries, you should never forget what is there. It is the 4 phases of soft tissue healing. It applies to bone, it applies to skin, it applies to everything you want. It all starts often with an injury in our field. And then of course you have hemostasis, and then you move on in the chain, and you end up with, when remodeling and maturation is done, you end up with healing. What's the problem with the chronic tendinopathy? Why is it that people will drag this for months? We'll see several clinicians. We will use different agents, but it's still there. What's going on? The problem is here. It is in the inflammatory and proliferative phase that this agent has its place. I like when and you've seen it perhaps in my book, that I like to know when it's time to use an agent. I think that's something that we must do. It's okay to pick one up, but we should not be using the one that we have in our clinic to treat. We should be using the one that is needed. And how to know if it's needed? By trying to clinically establish where your patient is in this framework. Okay, I'll come back to this. Now, you will ask, you remember, you're here also to optimize your practice through evidence. Am I talking over my head here? Am I telling you that it's good because I have shares of the company? No. No, that I can assure you. Nobody will buy my scientific way of looking at this. Nobody. And you too, I'm sure. So what I did, like everybody, I started to read on the topic. I attended the first one, actually it was, I think, the first international congress on shockwave, and when somebody has to go to bad places, I ended up in Rio de Janeiro in Brazil, and so it's terrible, but it's okay. I recommend you go there, and you will see at the Olympic how these beaches are beautiful. So, to make a long story short, I was able, only in my book, to pick up over 115 studies, not to show that it treats well the rats or the pig or the horses. These are all human-based peer-review articles. And the picture is this. Feel confident that this is something you can use, scientifically speaking, for these 4 conditions. Shoulder tendinopathies, whether the tendon is calcified or not. You can use it for elbow tendinopathy. You can use it for Achilles tendon, patellar tendon, and plantar fasciopathy. Podiatrists are using this, physical therapists, physiatrists. I'm sure athletic trainers are using it too. The chiropractors are into it. I mean, everybody is there and can have a crack at it. The symmetry now. It's one thing, like our distinguished speaker mentioned, that, hey, the trilogy is telling you about frequency, duration, and amplitude in this field. Let me tell you that this is what you have to memorize here. Because when you decide to make a treatment, you're going to have to determine the energy per shock or the pressure per shock, depending if you use a focal or a radial. I'll give you an example of dosimetry in a few seconds. The number of shocks, the shock frequency, the number of treatments. When you establish this, you'll be able to calculate three things: the dose per treatment, the treatment time, and the total energy dose given to the patient at the end of your treatment. Here's an example. Application of focus, shockwave. I just made it up, this prescription. Let me talk to it. Energy per shock, I decided that it was going to be 0.18. Well, remember, the range is between 0 and 0.6. This is scientifically established. Above 0.6, you enter the zone of destruction. Okay? Number of shocks. I said 2,000 here. Usually, treatments are given between 1,000 and 3,000. Shock frequency. I said 10 here. The range is between 1 and 100. Treatment frequency. Usually, you treat once a week. Once a week. And how many treatments? Usually, one may be enough, but maximum 4 is usually what you see in the literature. If after 4 treatments, you don't have the results, and by the way, don't expect immediate results. It will take time. It may take as long as 12 weeks before your patient becomes symptom-free, because it takes time for those neovascularization and this releasing a growth factor and all this to trigger another injury that will build up in healing the situation. Now, here are the calculations. There's a few formulas, and you end up with dosage. In this case, 360 millijoules per millimeter square. Your treatment time, if you know how many shocks you're going to give, and you know the frequency at which you give them, this is basic arithmetics, and you end up with 200 seconds or 3 minutes and 20 seconds. And then the total energy, well, it's the energy during one treatment multiplied by the number of treatments, and you end up with that value. Here's a radial, same thing. The only thing that changed here is that I'm not expressing the energy in millijoules per millimeter square. I'm expressing it in bar. And the rest is my prescription. And there I can calculate this. Well, some of you will say, well, you know what? Formulas and calculation, it's not my cup of tea. You know, I prefer to be focusing on what I do clinically. Fully understand that. What did I do? In the last edition of my book, I build up online. If you log in, you will have access to dosimetric online calculators. You just enter a few parameters of those, and you click, and you will have the numbers I just gave you. So you don't have to memorize that. You don't have to do hand calculation now. It's there. And I invite you to use it, because it will make you appreciate what you're doing. It will give you some foundation to what you do, and you won't have to spend time with calculators doing all that. What I want you to know is what the formula means. That, of course, you need. But as far as doing the routine thing, this can do it for you. The application now, let me give you a few words about the application. When you consider applying shockwave, you consider those parameters: lesion size and depth. This is important because this is on this basis that you will determine if you should be using a focused shockwave or a radial. Give me an example. Focus means that the beam is focused. So the smaller your lesion and the deeper it is, go get a focused, use a focused shockwave. If it's larger, more superficial, radial shockwave will do. Location of the lesion, where is it? Of course, if you use focal, you will have image guidance. And if you use the radial, the patient will guide you. As far as the coupling agent, you will need aquasonic gel, like the ultrasound. This is a mechanical energy being transferred to the tissue. And you'll need a coupling agent. And of course, the applicator surface area, similar to what ultrasound is all about. How do you determine the size of your sound head It's based on the surface of treatment that you're gonna have to do to deal with. And here's the same thing. If it's a small lesion, you use a smaller head. If it's a larger one, you use a larger one. Applicator displacement. It can be static or dynamic. It would make sense with focused shockwave to use static only, because you want to get there like the surgeon does when you do lithotripsy, okay? And analgesia, not required. Now let's talk about the case, okay? Let's see, let me try to put for you what I just said, which was an overview, and put it into a case that you may have. Right now, if I was to ask you, how many patients do you have right now that have chronic lateral epicondylalgia, and that they have been with you for a few weeks, a few days, or they come from previous treatments and their history is really big? First of all, when we deal with chronic elbow tendinopathy, one thing is clear. We're not dealing with a tendinitis, okay? We're dealing with a tendinosis. What's the difference? You know, a tendinitis is that you have all the reason to believe that there is an inflammation there. So that will require a special treatment. But the evidence show that somebody that has a tennis elbow and it's been dragging for 3 months, 4 months, there's no inflammation there. How do we know that? Well, you took a biopsy and you look under the scope. And what they found is that at the insertion, the tendon part of the ECRB, the extensor carpi radialis brevis, one of the most powerful wrist extensor that you have, it is there that the problem is. And what do they find? They find some immature repair tissue. And the name given to that is angiofibroblastic hyperplasia. That is, there was an effort by the tissue to heal, because you get chronic tennis elbow usually by overuse. It's micro tear that adds up over the weeks, over the months, and create that problem. And then if you look at it under the microscope, this is the kind of an immature tissue. And the process is stalled. Remember the slide previous, inflammation and proliferation? The mechanism of healing is stalled. That's why something is gonna have to happen to this patient. Otherwise, you could drag that thing for still more months. So what I've done here is to list the therapeutics that is available to you. And you're familiar with all of them. Briefly, I ranked them from level 1 to level 4. Level 1, of course, what do? We use rest. Of course, we use a brace. We may use over-the-counter medication. We will use ultrasound. We will use transverse friction. We will use progressive strength training, stretching. It doesn't work. What do? You, or I know as physical therapists, we will say, okay, well, let's have a look at medicine. What can they do? So you refer that to somebody you know. Physicians medicine look at this. You're a general practitioner usually. They say, okay, we'll try an injection. I will inject you with 4 different things. What's the basis behind those injections? Quickly, corticosteroids, you know, it's to kill inflammation. Why? There's none. So the evidence is not too good in using this today. Now, what about botulinum toxin? This, when injected in the ECB, will paralyze it for a few weeks, for a few months. Therefore, relaxing it, therefore allowing this muscle tendon to heal. Makes sense, doesn't it? And it's used. It doesn't work. They may use prolotherapy. What's prolotherapy? It's injecting an irritant substance in the muscle and tendon. It is to cause an injury. Remember, needling is causing an injury. You will make the area bleed, and that's a good idea. That's a good idea to try to trigger that healing process, but it doesn't work. So what do we do now? We go for platelet-rich plasma injection. What is that? Take the blood from the patient, go to the lab, process it, come back with a plasma that is very, very rich in platelets. And then you re-inject this into the site of lesion. This contains a ton of growth factor. And the rationale here, the scientific rationale, is that this is going to trigger the healing process. But it doesn't work. As of 15 years ago, what was the next step? There was no 3rd level. Surgery. Go for surgery. This is the purpose of my presentation today. I hope at the end, and you will see a little bit later, that I'm convincing you that it is worth trying extracorporeal shockwave therapy for everything I told you about and the scientific basis I gave you. Because if you skip that and you go for surgery, what's there for you? Open surgery, you'll see that shortly. Arthroscopic surgery, yeah, it's less invasive. It's faster, less demanding for the patient, but still a surgery with all the surgical risk and the long recuperation that comes with it. Recently, as of about 10 years ago, surgeons used histotripsy. The word tripsy, yeah. What is that? It's called a FAST technique. It stands for focal aspiration of soft tissue. What is that? Briefly, they use an ultrasound. Here we go. But this time, friends, it's high frequency, similar to a MEG, but the amplitude of this frequency is, we're talking here of way, way large shockwave energy, very, very large, that will pulverize the angiofibroblastic hyperplasia tissue. You don't remove it with a scalpel anymore. You just pulverize it with an ultrasound device. And then this device is coupled with a mechanism to aspire the material. So it's aspiration after. So you just introduce the needle, you withdraw the needle, you put a little Band-Aid, takes about 20 minutes. Still surgery, but much better than the two previous ones. Now we'll present two short videos. I'll give you a choice. Do you want this open surgery treatment for your chronic tendinopathy, or do you want the next one, which is application of shockwave therapy? Let's have a look at those.
This is Bobby Chalmer, and this is our approach for open treatment of lateral condylitis here at the University of Virginia. So I use a oblique incision just the anterior to the lateral epicondyle. Careful dissection is performed down to the level of the fascia. Usually there's no significant cutaneous nerves at this region. Hemostasis should be obtained, and careful dissection performed, exposing the underlying fascia and exposing the interval between the ECRL and EDC tendons. I tend to keep the forearm pronated during this approach to make sure that there's no traction injury to the posterior anterior nerve. The interval between ECRL and EDC is carefully created and dissection performed to expose the ECRB origin as shown here. The pathology is at the level, frequently at the level of the ECRB origin, and the goal for this procedure is to resect any of the abnormal tendon, as shown here. This is done meticulously so that all abnormal tendon is resected. This should also be done carefully as the radiocarpal joint is just below you, and you should not violate the underlying cartilage. The lateral epicondyle should be exposed. The anterior portion should be exposed to prevent iatrogenic injury to the lateral thoracic ligament. The epicondyle is exposed and a partial epicondylectomy is performed. I then drill the epicondyle to enhance healing with a 0.45 K wire. Once this is completed, the interval between the ECRL and EDC is closed, incorporating the underlying ECRB tissue, so a side-to-side repair is obtained of the ECRB tendon. An exam can be performed of the collateral ligament to ensure there's no posterior lateral rotatory instability. A watertight closure is obtained to make sure you do not have problems with a synovial fistula that can develop if there's not a watertight closure. Hemostasis is obtained after dropping the tourniquet and the skin is closed using an absorbable suture. I place the patient, after appropriate dressing is placed, I place the patient in a posterior splint until their first post-op visit of 2 weeks, at which point various therapy regimens are initiated.
Okay. Here you go. Now, do you want that or the next one? Keep in mind, you know, you have clinical background. You know that this is, first of all, let's make everything goes well. You don't have any post-surgical complication. Second, in a brace, it's 3 months, it's 4 months, it could be 5 months. But the success rate with this, because we tend to think that because it's surgery, it works. Well, I don't know if you read the literature like I do, but no, it's not because it's medical or surgical that it works. They have the failure. And here, this success for this is roughly between 70 and 85%. There will be a 15% patient that will go through this and will be back to square one. Because, how do I go to the next? Okay. Because then we didn't have this option. I'm not saying that this option is miracle, because the success rate for this is similar to surgery. That's the good news. It will not heal everything. But look at how easy it is. Radial shockwave. You won't see image guiding. Sometimes they say that silence is worth a lot of words. Compare. With equal success rate. By the way, shockwave therapy, radial and focus, has now been approved in the States. It's FDA approved for 2 conditions, tennis elbow and plantar fasciopathy. Okay? Now, the bottom line. The bottom line of this presentation. Well, I think, I'm convinced anyway, I hope I was able to convince you, that this form of therapy is, without a doubt, promising, it's evidence-based, and it's worthy of recognition by all of us dealing with chronic soft tissue conditions like tendinopathies. Now, I will answer 2 questions here. Which one is best, focused or radial? Where do you should put your money? Well, the evidence shows this. They're both practically equal. The only thing that will change is that if you're dealing with conditions that are very small and deep, then you should favor the focused. More expensive, but get a better result. But practically speaking, for most, you'll see that. Answer to the second question. You might have seen my flyer via Dr. Valdez. What are we talking about here? Are we talking about something that is sham therapy or perhaps a breakthrough? Well, I think based on what we know today, and God knows what's going to happen in the next 10 years, is that we are closer to a breakthrough. Will it be nice if we can get rid of surgery? Orthopedic surgeon will not be happy. We know that. But we will be extremely happy. Not because of us, but the patient. Let's not forget what the patient goes through. All right? So, in my view, closer to a breakthrough with this particular treatment. In closing now, let me thank sincerely all the sponsors, the Mount Royal University alumni, MedWest, of course, and the Alberta Athletic Therapists Association. I was received like a king, and I really enjoyed being here with you. And of course, special thanks to this man here, Dr. Valdez, that we exchanged a few emails over the past few months, but look at this, everything's worked perfectly, so thank you so much. And now, I thank you, but you know what? I welcome your questions, but I have a deal. If your questions are too difficult, then my two distinguished guests here will answer them. They both said yes, because we discussed that last night. So thank you very much.
We'll have Mark facilitate one question just for time's sake, and again, we'll have an opportunity for Q&A at the end. So I'll just hand it over to Mark.
Just because we have an online question, I thought we'd address that. The person in Savannah would like to know if there are any contraindications to shockwave therapy.
Yeah, I would say the major one is people that have blood disorders, coagulation, those that are on blood thinner. That is perhaps the most, and of course, never over an area that was exposed to radiotherapy like a tumor, and not over an acute area, of course, because you will amplify the situation. So roughly, this is pretty much what, but the most important, the most important one is blood issue, because you will bleed.
Thank you.
Thank you so much. Thank you again, Alan, for a great presentation. Once again, we'll take another wellness break. So we'll restart again in about 5 minutes, and Nick will ring the bell in 4. Okay. Okay, welcome back. Okay. Welcome back. I just wanted to make sure that our online audience is still there. But welcome back. Before the last speaker, we're going to have Mark do one more door prize.
And joining me up here is another alumni, and I thought I'd bring the picture. Wearing a different hat today. So I nominated Brandon and John last year for an Alumni Horizon Award, and again, I'm flogging the Alumni Association stuff because I really want to see us grow that part of it. So we're going to do another draw. Thanks, John, for coming and doing that. Let's pull up the magic box. Close your eyes. Oh.
Christina Luciani.
Let's see if she's tricked about the fairness.
That's my mother, right?
Yeah.
Good, excellent. Share it with your friends.
But you don't have one of these. So Larry graciously donated, what is it, Larry? A TENS unit? Fantastic. So congratulations, Christina, for having a TENS unit. Next on the agenda, we'll have Rita come up and introduce our final speaker.
So they've all been talking about how important there is of the Holy Trinity of modalities, and we've got our last speaker here, Dr. David Draper, and he comes to us from the Department of Exercise Science at Brigham Young University. And he was the head athletic trainer at Illinois, I didn't get this wrong, Wesleyan University, prior to his appointment at BYU, and he has a whole list of accolades and awards, just like our other two distinguished speakers today, including the most distinguished athletic trainer in 2009. So again, my plug for the textbooks. You too co-wrote this textbook, Therapeutic Modalities Added to Your Trinity, and let's welcome Dr. David Draper.
Thank you very much. This has been one of the best seminars I've been to before because these two guys here, this is incredible. I have had their textbooks for years. I talked with Dr. Ballou over in Brazil a couple of years ago and became a big fan of him. And I've had all of his textbooks since I was young. And it's just amazing. I've always thought this shockwave therapy would be neat. And now we have to go home and buy one at BYU. So thank you, Cougars, for being here. How many are Mount Royal Cougars? Raise your hands. I'm a Cougar too, Brigham Young University Cougars, and we both have blues, so that's a good sign. Today I'm going to talk to you about something that's been around a long time, and that's ultrasound. But I'm also going to share with you a new type of ultrasound that I don't think anyone in Canada has heard about yet. In fact, probably only 1% of the athletic trainers in the U.S. know about this sustained acoustic medicine that I'm going to talk about. So we'll kind of start with the old and how to improve the old and then bring in some of the new. Now, I have a passion for ultrasound. This was in Brazil and we're going there again in October, and they took us to a factory that made modalities, and that's like taking a kid into Toys R Us for me, because I'm a modalities geek, and I saw this bucket full of ultrasound heads, and I said, I've got to get a picture of that. So I love ultrasound. It's my favorite modality, and it's used an awful lot in the country and throughout the world. I thought we would start with a little bit of a quiz. I see out there you're studying for finals. Right now, my students are taking a final exam in Provo, Utah, so you can't get off the hook. So write down number 1 to 15, and we'll see how well you do now, and we'll review this at the end of the presentation. So question number 1. Which of the following would respond best to a 3 megahertz ultrasound treatment? A, subacromial bursitis, B, lateral epicondylitis, C, soleus strain, and D, piriformis syndrome. So what would be the best for that frequency? Go ahead and jot down the answer, and Dr. Valdez will be buying you a brand new course for whoever wants this. Question number 2. Which of the following would respond best to a 1 megahertz ultrasound treatment? A, medial epicondylitis, B, long head of the biceps tendonitis, C, patellar tendonitis, D, quad strain. And I'll give you a hint, it's a deep quad strain, okay? All right, because there are superficial ones too. Okay, number 3, which ultrasound frequency heats the fastest? Which ultrasound frequency heats the fastest? Is it A, 1 megahertz, B, 2 megahertz, C, 3 megahertz, or D, 90 kilohertz? Number 4, which structure heats the fastest? Is it A, tendon? Is it B, ligament? Is it C, muscle? Is it D, fat? Number 5, what is the appropriate treatment size for thermal ultrasound? Blank times the size of the sound head. Is it A, 2 times the size of the sound head, B, 4 times, C, 6 times, D, 8 times the size of the sound head, or E, none of the above? Question 6. Ultrasound is most effective when moved at a speed of what distance per second? Is it A, 4 centimeters per second? Is it B, 6 centimeters per second? Is it C, 8 centimeters? Is it D, 10? Or speed of sound head movement is not a factor with ultrasound. Question 7. The acronym ERA refers to A, the type of tissue being treated, B, percent of the crystal that is transmitting the beam, C, the duty cycle, D, the energy produced by the crystal, and E, 2 of the above. Number 8, driving medication into the tissues via ultrasound is known as A, attenuation, B, iontophoresis, C, phonophoresis, D, none of the above. Number 9, which of the following are contraindications for ultrasound use? A, sprains, B, strains, C, over implanted metal, D, cardiac pacemaker, E, 2 of the above. Number 10, raising the muscle temperature to about 40 degrees Celsius. So if we started a baseline of 36 degrees Celsius core temperature and raise it up to 40 degrees Celsius, about a 4-degree increase, that is required for what conditions? A, phagocytosis, B, pain relief, C, acute tendonitis, D, muscle spasm relaxation, and E, stretching. Okay, now we have some true and false ones. 11, a measure of ultrasound energy is called a joule. True or false? A measure of ultrasound energy is called a joule. True or false? 12, an ultrasound treatment can be applied for over an hour. True or false? 13, an effective ultrasound treatment should deliver at least 2,250 joules, roughly just over 2,000 joules. Is that true or false? Number 14, ultrasound can be effective into the tissue for up to the size of a baseball. True or false? And last, ultrasound machines are big and bulky, about the size of a laptop computer. Okay, so we'll grade these at the end and you'll all have 100% at the end. I like history. It was fun listening to Dr. Ballou talk about Yakov Kotz and Dr. Bill and Jay and I last night, we had a nice discussion about Kotz, and he was actually worked in the 76 Olympics in Montreal and learned of Kotz's work and so forth. Well, there's a little bit of an interesting history with ultrasound too. Prior to World War II, German scientists were experimenting with sonar in submarines. Sound was emitted from the vessel to detect objects in the surrounding water. The scientists noticed that fish were destroyed in the process. Thus, the idea of ultrasound producing biological effects was born. Now, most of the time when you talk to the lay person about ultrasound, they're looking at this. Okay, I'm the proud grandpa of 7 grandchildren. Our 8th is on the way, middle of July. And my daughter showed me the ultrasound. And any of you seen the 3D ultrasounds they do now? Any of you seen those? They're amazing. I mean, it's just amazing how they look. And so the science has really moved along. But what we're talking about here is therapeutic ultrasound, and where like 99% of the time it's used for the thermal effects. Now, there's an advantage of ultrasound over other thermal modalities such as whirlpool, hot pack, paraffin, is that structures high in collagen, tendon, ligament, muscle are heated to a vigorous level without overheating the surface. You can put a hot pack on someone and you can burn them. It's very difficult to burn someone with an ultrasound machine. Now, at our university, we do a lot of studies where we put temperature probes into the muscles of our students. And then we will do ultrasound to see how much the temperature goes up. We'll put an ice pack on to see how much the temperature goes down. We did this with our students, and we usually pay them $20 American, which is a good 5 meals at Taco Bell. So it's a good bargain for them. But if you notice here, whirlpool, a warm whirlpool at 1 centimeter will raise the temperature 3 degrees Celsius, but at 3 centimeters, only about 1 degree. So it's a superficial heater. The same with hot pack, it's about the same. Paraffin wax at 1 centimeter will raise the temperature about 2 degrees, but it won't raise it at all deeper into the tissues. If we were to put ultrasound out there, depending on the frequency, ultrasound can raise the temperature 4, maybe even 6 degrees if you're using 3 megahertz at 3 centimeters deep. So the only 2 deep heating modalities that I'm aware of are ultrasound and pulse shortwave diathermy. Now, how many of you have pulse shortwave diathermy? Typical. We just don't. But the nice thing Ultrasound, in order for it to be effective, you've got to treat an area 2 times the size of the sound head. If you start getting bigger than that, it doesn't heat very well. Diathermy can heat up an area as big as a diathermy drum. And so I'm on the bandwagon to try to bring diathermy back because we need that deep heating modalities. Now, there are some thermal physiological effects of ultrasound: increased extensibility of collagen fibers, reduced viscosity of fluid elements in the tissues, decreased joint stiffness, reduced muscle spasm, diminished pain perception, increased metabolism, and increased blood flow. Some of the non-thermal effects are wound healing, vascular regeneration, increased phagocytic reaction of the macrophages, increased protein synthesis, tissue regeneration, cell membrane alteration, and increased capillary density of ischemic tissue. There are some contraindications to ultrasound. One would be thermal ultrasound when tissue temperature rise is not wanted. So you wouldn't be using thermal ultrasound when you should be using RICEs, rest, ice, compression, elevation, and stabilization, because it would just add to the swelling to the area. Areas of lost sensation, you wouldn't be able to tell when it's too high. Areas of decreased circulation. For example, I've got a friend who is diabetic and he has a lack of sensation in his hand. I would not use ultrasound on his hand in the thermal mode, because how blood flow gets to increase with ultrasound is we have homeostasis. We have a set point we're comfortable at. As a tissue starts to raise up too high to where there's a fear that it might damage the tissue, the body sends in blood flow to the area to prevent overheating. So if somebody doesn't have good circulation, thermal ultrasound would be contraindicated because it could actually damage the tissue. Over the eyes, reproductive organs during menstruation with a pacemaker. But that doesn't mean you can't treat an ankle. I had a neighbor years ago that had sprained her ankle, and it had been a week past the ankle sprain. And I said, why don't I do some ultrasound? She said, stay away from me. I have a pacemaker. Okay. It's pretty well known that you stay away from the general vicinity of the pacemaker. In fact, one company has come out and said stay about 6 inches away. Now they've come out with pacemakers that don't even have any wires. And so you could treat bicipital tendonitis in the left shoulder with ultrasound and be fine if a person had a pacemaker. Malignant tissue, that could cause a tumor to spread. Active infection. Epiphyseal plates is now a precaution. If you look in Jim's book on ultrasound, it says that now they recommend to stay no more than 1 watt per centimeter squared. Okay. The original contraindication was found in laboratory rats where they did ultrasound over epiphyseal plates and they prematurely closed the plates. But they used 3 watts per centimeter squared. That's way too high. Most ultrasound machines won't go that high. Just this past week, I finished treating a 10-year-old girl who had dislocated her elbow 6 months ago. And she's been going in for physical therapy, and the physical therapist used hot pack or used hot whirlpool and stretching and couldn't get her range of motion back. So she came into my lab. I use ultrasound because it'll heat the deep tissues, and I use joint mobilizations to get at that capsule that's inflamed, and was able to restore her range of motion. But I kept the ultrasound machine under 1 watt per centimeter squared, and there was no problems whatsoever with her growth plate. Now, facts and misfits. I was honored a year ago, asked by the European Journal of Physical and Rehabilitation Medicine to write an article for them. Years ago, and I see a smile here by Mark, years ago I came up with an article called The Top 10 Mistakes Clinicians Make When Using Therapeutic Ultrasound. And that's got a lot of press. A lot of people have been interested in that. And he said, let's revisit that. Come up with the facts and misfits of ultrasound. So I came up with 7. So 7 steps to improve treatment outcomes.
treat the correct size area. 2, use the appropriate treatment duration. 3, avoid using preset intensities. 4, use the correct frequency. 5, don't treat all tissues the same. 6, move the sound head at the appropriate speed. And 7, be aware of the stretching window. And Dr. Berlinger last night mentioned be aware of how much subcutaneous tissue they have there, how much fat they have in the area. So let's quickly look at each of these. I love this drawing. I worked in the 2002 Winter Olympics in Salt Lake City, worked long track speed skating. And in order to do that, I had to work at a World Cup championship. And so I worked at the World Cup championship in 2001. And I went in to the Canadian, and I love Canada. One of my colleagues is from Canada. But I went into a Canadian physiotherapist room where they were treating this world-class speed skater, and they ultrasounded the entire low back. What good did that do? Nothing. That was pure placebo. Okay, so why do we know this? Well, we did a study at BYU some years ago, and we compared an area 2 times the size of the sound head and 6 times the size of the sound head. Our baseline was 36 degrees Celsius. 2 times the size of the sound head, we got an increase of 4 degrees. And this was when we were using 1 megahertz at 1.5 watts per centimeter squared for about 12 minutes or so. 4-degree increase, 2 times the size of the sound head. When we went 6 times the size of the sound head, and that's not very big, folks, 0.5 degree increase. Ultrasound was made to treat small areas. That's why we need pulse shortwave diathermy. You can buy them for $6,000. That's not that bad. That's US dollars. I don't know what that comes to in Canada. I thought, heck, you guys have good gas prices. I saw gas for 97 cents a gallon the other night. Okay, I'm moving to Canada. All right. So the recommendation is to treat an area 2 times the size of the sound. Okay, now you've got a quad strain. You can't do a whole quad with ultrasound. So what I recommend is find out the area that's the source that hurts the most, treat that area. And hopefully that will get a cascade of healing going to the rest of that. Okay, number 2, use the appropriate treatment duration. I travel around the globe doing presentations. I will go back to Utah on Monday, go into the training room, and you'll have all of our staff doing 6-minute treatments. They don't read my stuff. Dr. Bully knows. You know, we come here, we're treated like kings. We go back here and go, there's that treatment kid. But you need to have a treatment goal. And so there are some treatment goals here. And so, for example, 3 megahertz he's 3 times faster than 1 megahertz. You got a crystal deforming 3 million times per second here and 1 million times per second here. This is going to heat up 3 times faster. So tissues that are more superficial, you don't have to go as long with. That's where my athletic training staff might be okay if they're doing 3 megahertz, okay, unattended. But if they're going 1 megahertz, that just wouldn't be enough. So when using 1 megahertz, in general, whether it's 1 to 2 watts per centimeter squared, your treatment should be 10 to 15 minutes, okay? When using 3 megahertz, it should be 5 to 8 minutes roughly, okay? Now that if you're using a good machine, and there's a big variability in machines. I don't make money for this company. I do research for them, but they're called Accelerated Care Plus. They're out of Reno, Nevada in the USA. Best ultrasound machine on the planet, in my opinion. And that's going with research that's been done by Don Gulick at Widener University, who is a PhD certified athletic trainer and physical therapist. Dr. Mark Merrick at The Ohio State University, Dr. Bill Holcomb at UNLV, and me. And we tested probably half a dozen different type of ultrasound machines, and the Accelerated Care Plus machine, the OmniSound by AC Plus, heats a third higher and faster than all the other machines. So the machine does matter. So that's why it's extremely important to use the right parameters. I'm not saying go out there and sell your machine and get a new one. Make sure you use the right parameters and be conservative with those. Number 3, avoid preset intensities. When I went to college in the late 70s, early 80s, everything was 1.5 watts per centimeter squared. Okay, I don't know if they still teach that. But what you should do is go according to patient tolerance, because if I'm doing, here's my ultrasound head, and I'm treating his brain because I want some of that brain, okay? So I'm treating him, okay? If he says that's too hot, I don't say tough. My teacher taught me 1.5. Tough it out. I have to go according to that tolerance, so I turn it down. So what I recommend is kind of a starting place, is because 1 megahertz is deeper structures and heat slower. I recommend start about 1.5 watts per centimeter squared, and 2 minutes into the treatment, ask them, how does it feel? If they say it's too hot, turn it down. If they say they can handle more heat, you can turn that up, okay?
I'm sorry to interrupt you.
Yeah.
I don't normally do this, but we just got a note from the people online, and we have to tether you back over in this general area because they can't hear you speak.
Oh, okay, all right.
I know that's bad, but
I get so excited, I want to move around. I'm sorry about that, people online. Okay, very good. So, and with 3 megahertz, what I like to do is start maybe at 1 watt per centimeter squared. A couple of minutes into the treatment, ask them how they feel. And if they say it's too hot, turn it down. If it is too cool, you can turn it up. Now, wouldn't it be, let's think about it for a minute. We want a 4-degree increase. We're going 1.5, and they say that's too hot, turn it down. If we turn it down to 1.0, shouldn't we add on some time? Sure we should. There's only one machine on the planet that does that for you, and that's the OmniSound by Accelerated Care Plus. Has a little computer in it. As you turn the temperature down, it adds on the treatment time before it shuts off. As you turn the temperature up, it decreases the time. It's really neat. It's like ionophoresis. Okay. Number 4, use the correct frequency. 1 megahertz absorbs energy from 2 to 5 centimeters deep, like piriformis syndrome, soleus, rotator cuff, etc. 3 megahertz absorbs energy from the surface to 3 centimeters deep, such as patellar tendonitis, Achilles tendonitis, plantar fascia, IT band, ankle ligaments, gastrocnemius, etc. So make sure you're using the correct frequency. Probably the #1 frequency we use in sports medicine is 3 megahertz because most of our structures are within those 3 centimeters deep. Don't treat all tissues the same. Tendon, due to its poor blood supply, heats 2 to 3 times faster than muscle. So if you're treating an Achilles tendon, you don't need to go 10 minutes. If you're going 3 megahertz, 5 minutes may be fine. Okay, that's something good to know. So recommendation, treat tendons 2 to 3 less time in minutes than muscle. Number 6, move the sound head at an appropriate speed. A lot of my students go out and they do rotations with athletic trainers at various high schools or physical therapists at clinics. One of the big things they see, well, the big one is treating too big of an area. And then the next one is racing that sound head. Boy, they're just moving it really, really fast, okay? There's a problem with moving it so fast is if you move it real fast, you start to slip into a larger treatment size, okay? So I recommend about 4 centimeters per second. Whether you go back and forth or circular strokes, that's fine. This is a medical device. It's not a deep massager and so forth with a lot of pressure. You should use it appropriately at around 4 centimeters per second, 2 times the size of the sound head. Number 7, be aware of the stretching window. The number one reason I use ultrasound is to decrease pain. Number 2 is to get range of motion back. And I've published a fair number of papers on people who have had frozen wrists and how we were able to get their range of motion back. So let me show you one here. She was in a paper that just came out a year ago. This is a former student of mine, 23-year-old college student who had right wrist triangle fibrocartilage repair and much lunate wear from 6 years of high school and junior high school sports. She was 1 month post-surgery cast. Took her cast off, had very little range of motion. Treatment, 3 megahertz ultrasound to the anterior and posterior wrist for about 5 minutes at 1.4 watts per centimeter squared. The reason I went 1.4 is that's all the higher the machine would go. Otherwise, I would have gone a little bit higher. Then I did 8 to 10 minutes of joint mobilization. So let's look at her pictures here. This is her uninjured wrist in extension. Here's her injured wrist in extension. Has very little extension there. After 5 treatments, the extension is equal. This is her flexion. Her uninjured wrist there, full flexion. Here she's about 45 degrees. She needs to get down to 90 degrees flexion. Here she is after just 5 treatments. Look at this, no radial deviation whatsoever. After 5 treatments, equal radial deviation. Before 5 treatments, had some ulnar deviation, full ulnar deviation after 5 treatments. And I've done this with dozens of people, and it's been so very, very effective. You try it with a hot pack, you try it with Whirlpool, it just won't work. And the key is the joint mobilizations too. Now in the United States, and I think somewhat in Canada, there are purists of the physiotherapists who think all they need are their hands. They just want to do manipulation. Why not heat up a structure before you use your hands? Because by heating it up, you're going to make the tissues more willing to be stretched and moved and so forth. So don't ignore the stretching window. Basically, from the time you finish that ultrasound treatment until it cools down too much to move it is about 7 to 10 minutes. So you don't have time to check your emails. You don't have time to run to the restroom. You don't have time for a coffee break. Immediately when you're done with that ultrasound treatment, start stretching them or do your joint mobilizations. There are some myths. Ultrasound can be used over metal. I've used it several times, okay? It heats up structures high in collagen. It does not heat up metal. Total knee because of the glue, that's kind of iffy out there. Okay, that's kind of iffy out there. If you are just using ultrasound mainly for a little bit of pain relief and you're maybe going just a half a watt or 1 watt per centimeter squared, you'd probably be fine. But I wouldn't want to do a lot of heating in there for like getting range of motion back. Ultrasound, you can cross the spine with ultrasound. Some people feel you can't. You can cross the spine. And then there's all these menthol-containing lotions. How many of you use BioFreeze as an ultrasound medium? Raise your hands. It's used a lot in the U.S. How many of you use Icy Hot? How many have heard of Icy Hot? We've all heard of Icy Hot. Some people use it as an ultrasound medium. Those are not good mediums. Okay, the reason Icy Hot works, and I read a paper on this just the other day, where they put temperature probes in 2 centimeters deep and on the surface, and Icy Hot didn't cool the tissue and then didn't warm it up like Shaquille O'Neal will make you think it does. Okay. The temperature just kind of didn't do much at all. But it gives you the sensation of heat or cold because it has menthol. BioFreeze gives you the sensation of cold because it has menthol. Flexol, Blue Emu, all of those things give you the sensation of heat or cold because it has menthol. So I don't mind using those as a couplet, but not at 100%. If I want that good feeling they get from rubbing on that counter irritant, I will use 1 part of the icy hot cream with 3 parts of ultrasound gel. So mix it like that, and then you can get the added benefit of the menthol. Okay, a joule is a measure of work or energy. There are several studies that claim ultrasound does not work. There are a lot of meta-analysis out there that just blast ultrasound and say it doesn't work. But as I've read some of the studies, they treated too large of an area, their treatment duration wasn't long enough, and they used the wrong parameters. They used 1 megahertz when they should have used 3 megahertz. There was one study that they took ultrasound and treated the medial joint line of the knee for 3 minutes, then did a valgus force on the knee. It didn't open up any more than normal, and so they said ultrasound doesn't work. That's a stupid study. But they're using things like that to pat themselves on the back that all they need are their hands and they don't need ultrasound. So the key is you have to have enough energy delivered for ultrasound to work. A joule is a measure of work or energy. The articles that support the use of ultrasound use the appropriate joules to reach the treatment goals. A joule is a unit of work or energy. It's crystal size times the intensity times the time in seconds. So for example, if you had a 5 centimeter squared crystal, which is about the size of American quarter, and I'm guessing about the size of a loonie. I don't know. I'm thinking so. I had one years ago. But that's a typical ultrasound crystal size, okay, 5 centimeter squared. At 1.5 watts per centimeter squared for 10 minutes, you've got 4,500 joules. So that's considered enough energy to get the job done. So here are some studies that all showed ultrasound worked, okay? Downing and Weinstein used 1 megahertz on supraspinatus tendinitis. They did a group at 1 watt per centimeter squared and 2 watts per centimeter squared. The treatment time was nearly 16 minutes. They had anywhere from 4,000 to 8,000 joules. These people got better. Eppenbleicher et al. In 1999 used 1 megahertz for calcific tendinitis. 0.5 watt per centimeter squared, but 15 minutes worth. 2,250 joules, this was effective. Shamato et al. In 2002, 3 megahertz for calcific tendinitis, 1.2 watts per centimeter squared for 6 minutes, that came up to 4,300 joules. These people got better. And the last one, 1 megahertz hip osteoarthritis, 1 watt per centimeter squared for 15 minutes. This was 4,500 joules. These people got better. If you look in the literature, the studies that say ultrasound doesn't work, they're under 2,000 joules. That's one of the big problems. So, the new type of ultrasound that I'm so excited about, I'm going to come out here and then come back. I met the guy that invented this about 18 months ago. And when he was a PhD student at Cornell University, he attended a thing where they could stand up and in 1 minute talk about something they invented. And basically what he said is, I'm George Lewis. I've invented the smallest ultrasound machine in the world, and it's going to change the world. Pretty cool. You know, you got to listen to this, though. This is neat. Sustained acoustic medicine, or SAM, delivers up to 18,720 joules per treatment because it is applied for up to 4 hours. Look at the size of that. That's your cell phone right there, folks. Okay. So this is the ultrasound device. This is the crystal that has a little patch that applies it to the area. It can be worn up to 4 hours. Imagine getting that ultrasound energy for 4 hours. Wouldn't that be neat? Okay. Low intensity, the reason they can deliver it up to 4 hours is because it's 0.132 watts per centimeter squared. It's 100% duty cycle. It is possible to deliver these long-duration, low-intensity treatments because the device is portable, small, about the size of a TENS unit, battery-operated, self-administered, comfortable, worn during the day of course of daily life. So this individual here has a bicep strain. So she's put this sustained acoustic medicine on there. It's very easy to do. You push one button to make sure it's charged. You push another button. Every time you push it, it gives you another hour, up to 4 hours. It's indicated for relief of pain, relief of muscle spasms, and local increase in circulation. This is what the crystal here looks like, and it's the size of a US 25-cent piece. So this is kind of a brick wall here that we run into with several modalities, and this is breaking through the brick wall. It says SAM is sustained acoustic medicine, self-applied for long duration ultrasound therapy for a treatment of up to 4 hours. Each 4-hour SAM treatment provides 18,000 joules. That's if you use 2 crystals of acoustic energy with an easy to apply bandage. It comes in these different wattages here. The main one is 0.132 watts per centimeter squared. 3 megahertz. Now they're coming out with a 1 megahertz device. It'll go deeper. So here's some studies. They did a study on chronic trapezius myalgia. They had 30 subjects, and actually we participated in this study at BYU. So we recruited 30 people that had pain, had upper trapezius pain. And 15 of them got a device that worked. 15 of them got a placebo, but it was double blinded. The nice thing about this is we didn't know which was which, because if I knew and I said, I really like you people at Mount Royal University, I'm going to give you the device that's going to make you better. But I don't care about the people at the University of Calgary, so I'm going to give them the sham device, okay? I couldn't do that. I couldn't play favorites because I didn't know what machine was what. All they had is I'd give them a machine, tell them to wear it for 4 weeks, 4 hours a day for 4 weeks, repeat back every week. And we sent the machines back. We sent the data back. Then the company tells us who was sham and who was not. And there was about a better than a 30% increase in decrease in strength among those who wore the device compared to the other. Knee osteoarthritis. They did a study on knee osteoarthritis and found this sustained acoustic medicine had a great reduction in pain and better improvement in movement scores and so forth. Now, they hired us to do a study on muscle because they wanted to make sure if you wore this for 3 hours, would it overheat and actually burn the tissues. And so we put temperature probes in 1.5 centimeters deep and 3 centimeters deep into the gastrocnemius muscle, and we did our ultrasound treatments. And as you can see here, we got a temperature increase of over 4 degrees at 1.5 centimeters deep and over 3 degrees at 3 centimeters deep. So that would be good for increasing blood flow, decreasing pain, and so forth. So these are some quotes from the knee osteoarthritis study. Very, very happy with this device. I hate to think about how I will feel not using it after returning it today. It has greatly improved my quality of life, and I think I'll be lost without it. Will highly recommend to anyone. Started a new exercise program. Couldn't have done that without SAM. I have seen such great improvement each day. SAM is seriously a miracle for me. I'm almost pain-free. I know I have to give SAM back at the end of the study, but I don't want to. I feel human again. So quite a lot of things after people with osteoarthritis pain. Now this was our pictures that we did for our muscular study on temperature increase. This temperature probe in here is 1.5 centimeters deep. This is 3 centimeters deep. We are the only university I'm aware of in the States that yet then uses imaging ultrasound to see how deep those probes actually are. See, we measure down and then we put the probe in and hope we're 3 centimeters deep, but this will tell us that maybe we're at 2.8 or whatever. And on average, we are only a tenth away on the depth. This is showing then the 2 crystals being applied. So with 2 crystals, it can treat an area up to the size of a baseball. Past research and review then, studies on knee osteoarthritis, shoulder tendonitis, and trapezius muscle spasm have all found the SAM to be effective in substantially decreasing pain. And a study at BYU found that the SAM produces moderate to vigorous heating in human muscle. So, astronauts are interested in this because when astronauts go up to space, they become weightless and they actually gain about 2 inches in height. And a lot of that has to do with the disk space. So when they come back and gravity hits, they're at a greater propensity to rupture a disk. So it's kind of interesting. We received a grant from NASA for $250,000 US to study back pain. And so one of my former doctoral students, who's a professor about an hour from me, is going to collect 25 subjects, and I'm going to collect 25. And they have to be between the ages of 20 and 60. They have to have a herniated lumbar disc. They have to be willing to go off pain meds, and that might be a little bit of a problem, but we're going to try to do the best we can. On a visual analog pain scale of 0 to 10, they have to be at least a 4, 5 days out of the week. So they wear this device for 8 weeks, at least 5 days a week for 8 weeks. We take pain scores every week with them. We take what's called the Oswestry scale that measures movement and activities every week. We also have them wear what's called an actigraph that measures motion. And so people with back pain, anyone in here ever herniated a disc, or am I the only one? You don't sleep quite as well, okay? And this will measure how many minutes they actually sleep during the night, how many times they wake up. So the theory is that after using this SAM device, this sustained acoustic medicine, that they will sleep better at night. So it's going to be a fun study. We're really excited about it, and we're doing our pilot study now to collect some of the data. So who's using SAM? These are some pretty popular people in the United States. Kevin Wilk, who's with Champion Sports Medicine. I'm sure Jim knows who he is. Claude Mormon, MD, he's at Duke University. And Duke just won the national championship in basketball in the U.S. We have Tom Best, who's an MD, PhD at Ohio State, and then this picture's 15 years old. So I look much better there. But anyway, we're using this at BYU. Now, so ultrasound benefits. Ultrasound in general. Reduced pain. Reduced inflammation. Increased healing rate, non-invasive, and a simple treatment. Traditional is a large size. It's about the size of a laptop computer. Cost could be anywhere from $1,000 to $2,500, okay? Not portable. Treatment time 5 to 15 minutes, applied by a clinician, and there's messy gel. But this wearable solution, this SAM, there's no mess. It has a little hydrogel. So it's kind of like a gel shot, and it's very, very handy. You use it daily while you're sitting home relaxing. You can wear it while you're exercising if you want. And it's long-lasting and battery-powered. So will SAM ultrasound replace traditional ultrasound? No. No, you're not going to have someone come in your athletic therapy room and hook them up to this device. because they'd have to be there at least an hour, maybe up to 4 hours. But you could send them home with it. We have some we're using with our football team at BYU. It's great when they're on the plane flying back east somewhere to play some team. It's great when they're at the hotel room. It's great for after practice. They can wear it home with them while they're studying and so forth. And so that's where it's going to come in very, very handy. So traditional ultrasound lasts from 5 to 15 minutes, requires constant monitoring by a clinician, can reach the therapeutic level in 5 to 10 minutes, comes in both 1 and 3 megahertz, and is 0.1 to 2.5 watts per centimeter squared. It can use pulsed or continuous mode. Whereas this sustained acoustic energy is a very low intensity, long duration, 2 to 4 hours, static application, little monitoring by the clinician, takes about 30 minutes to reach the therapeutic level, but then it maintains that throughout the treatment. Comes in both 1 and megahertz in its continuous mode. So I think of SAM as another tool for clinicians to use. We not only have traditional ultrasound in the athletic therapy clinic, but we also have the sustained acoustic medicine they can take home with them. So there's the picture of it. Very, very handy little device. Okay, hopefully this will work.
Tissue remodeling is a complex physiological response that occurs after an injury. Natural limitations to this process often lead to mechanically inferior tissue, adhesions, and chronic pain conditions, especially in tendons, which have limited blood and nutrient supply. Sustained acoustic medicine, or SAM, is a new wearable technology that utilizes mechanical ultrasound waves to promote the healing cascade. Different from traditional ultrasound, SAM applies a mild mechanical stimulation to the tissue over multiple hours, providing enhanced recovery benefits. SAM's continuous ultrasound waves produce a convective flow called acoustic streaming up to 5 centimeters into tissue. Combined with an increase in heat and circulation, the sustained mechanical pressure increases the bulk flow, pumping nutrients and growth factors throughout damaged areas, enhancing natural healing. When SAM is applied, the mechanical forces activate cell membrane receptors, enhancing cellular proliferation. One important mechanism is the upregulation of transforming growth factor beta, which increases type 1 and type 3 collagen deposition and promotes native tissue regeneration. The result is greater tensile strength and improved biomechanical properties of the tendon. Sustained acoustic medicine, SAM.
So I think you could see that person with lateral epicondylitis could, just as one little example, derive a lot of benefit from this particular modality. Okay, let's get back to our quiz. See how we did. Anyone think they scored 15? You're off the hook. You don't have to give away a new car here. Okay. All right. Lateral epicondylitis. Why? It's the most superficial. The others are too deep. Okay. Quad strain. Why? Because 1 megahertz goes basically from about most of the energy is absorbed from 2 centimeters to 5 centimeters deep. So it'll get those deeper areas. Number 3, frequency that heats the fastest is 3 megahertz. Probably the one that goes the deepest is 90 kilohertz. We don't know how deep that goes yet. I haven't heard that it's been measured anywhere. Number 4, which structure heats the fastest? The tendon, because of the lack of blood flow. Appropriate treatment size for thermal ultrasound, 2 times the size of the sound head. Ultrasound is most effective when moved at a speed of what distance per second? 4 centimeters per second. The acronym ERA, I love those questions that say 2 of the above as a choice. My students hate them but it really tests your critical thinking, because you kind of look at this and go, yeah, B looks good, but gee, D looks good too. So you bite on two of the above, but it's percent of the crystal that is transmitting the beam. Phonophoresis, probably most of you got that one correct. Cardiac pacemaker, probably many of you put two of the above, but it can be used over metal. It will not heat up metal. Stretching, main thing there. 11, a measure of ultrasound energy is called a joule. That is true. An ultrasound treatment can be applied for over an hour. That is true. An effective ultrasound treatment should deliver at least 2,250 joules, roughly in that area, is true. Ultrasound can be effective in the tissue for up to the size of a baseball. If you're using the correct parameters, that would be true. Ultrasound machines are big and bulky, not anymore. And the cost is about $700 US, and that's not too bad for a nice medical device like that. And if any of you work in a clinic setting, you could rent those to the patients. And in the US right now, workers' compensation is paying for them. I don't know how that would work in Canada. But we've got some professional soccer players that have patellar tendonitis. We're going to use SAM on them, and their insurance will pay for it because they're workers. That's what they do, is they play professional soccer. So it's kind of fun. Well, thank you very much for your kindness. Another shameless plug for my book. But, okay.
I'd like to thank David for a wonderful presentation once again. We'll have Mark do maybe 5 minutes of a Q&A facilitation, and then we'll take another break. And then we'll move into a wide open Q&A for the rest of the event. So I'll hand it over to Mark.
Okay, we don't have any online questions, so.
So you had mentioned that they're keep increasing the megahertz on the SAM. It's very low right now. What would that do in terms of standing wave? Because the SAM's not moving.
I think because the intensity is so low, I have to come back to it. Because the intensity is so low, I don't think it's going to be any problems there with the standing waves causing any kind of damage. Yeah.
Did you say it was available in Canada or not?
Well, I'll give you the website and they'll send it to you. It's just called ZETROZ. Just Google ZETROZ, Z-E-T-R-O-Z, Z-E-T-R-O-Z.
And that's Z in Canada.
Is that Z in Canada? Oh, okay, all right.
They know the difference. They're good. I should be speaking over here. I should mention too, I'll get you in a second. So often Larry has done this for me where they have medical devices in the US, but they haven't gone through Health Canada yet. So Larry's been able to work his magic. So, and then do you end up contacting Health Canada, Larry?
Yeah.
Yeah. And then putting it on their watch list. And so I don't know if you have anything to comment about that from a Canadian perspective. No? No? Okay. Okay, Andrea.
I was just curious. I have a patient that has her bone breaks down as when it grows, so she's constantly having fractures in her bones. And so I don't know if it was Sam, but she bought some device like $6,000 where she puts it on. Have you heard of that? And then it builds bone?
Yes, that's a bone stimulator, and it has an ultrasound crystal in it. And it's some of the best evidence there is out there that ultrasound works. When people say ultrasound doesn't work, say, look at these bone stimulators, because people are getting better with non-union fractures and so forth. But I don't believe the SAM would qualify there. Yes?
Regarding the stretch window that you mentioned, would it be advisable then to do the ultrasound in a stretched position?
Absolutely. Absolutely. Yes. If you can put them in a stretched position while you're doing that, that would be wonderful. Very good.
And then to follow that up then, would you be able to combine the SAM with a stretch and a more specific flexibility program to help with contractures?
That's a good question. They've got the intensity so low that it takes a good hour for them to get up to this 4-degree increase. So it could sure be tried. I don't think it would be as effective as traditional ultrasound.
Just one last question before we go for break then. Down here.
No way. This guy's too smart, you know? He has to fly on a 747 just to accompany his brain. You know?
David, listen,
Yes, okay.
you know about likeness,
Yes,
right?
yes,
Low intensity
yes,
pulse, ultrasound.
yes.
Maybe I missed it. What's the frequency of sound? Is it, I'm sorry, is it continuous or pulse?
It is continuous.
Right.
And
That's
it
good.
and the frequency's 3 megahertz. They've just come out with the 1 megahertz. So it's called low intensity therapeutic ultrasound. It is lightest in a way, yeah.
It's like this, but with some, it's
Mhm.
not, it's continuous versus pulse,
Mhm.
because the duration is roughly 2-3 hours. Because over a fractured site, people can wear that during the day, and they will be exposed to ultrasound for 3-4 hours.
So you're thinking this might work for that? Okay. Good.
Thank you, Mark, for that. And we'll take another 5-minute break. And so we'll see you here hopefully in 4. Thanks again.
Thank you.
That was fantastic.
Thank you. Appreciate it.
to our guests. Okay, so before we start the Q&A roundtable discussion thing, there we go. We have one more draw, and I'll just hand it over to Mark to do the draw.
All right. So like I said, I think most people know Larry, but Larry is a grad from our program too. So I thought it was kind of neat to have alumni each time doing the draw. So Larry, you do the honors, and thank you again for donating the door prizes. Read your own buddy.
Jeff Bowling.
Oh, you're not here.
Oh, wow. Sorry.
She left.
Oh. Somebody text them. That say that they just. Too late.
Mike. Mike Elchuk. He left too.
Yeah, keep going, keep it going.
You gotta be here to win. Sorry, people online.
Casey Moffett.
She left.
Somehow we're gonna do that practice.
Judy Mackesy.
Judy.
Were you paying attention to everybody else is winning? So look, this is all you get. I get to take it. This is Dennis the Joker. Take whatever you want. Yeah. There you go. Okay, that's all you get.
We're just kidding. 1 second. Here's another gift donated by Larry and MedWest. So congratulations, Judy. Thanks, Larry, for donating the 2 TENS units, and again for all your generous donations. Thank you so much. I'm going to hand it over to Mark to facilitate the roundtable discussion. We can go back and forth between questions from the live audience and questions from the online audience. For those people out in the virtual world, again, feel free to use the online submission form. If not, I think I did send out my my cell number, so you can text me questions as well. And again, I'll just hand it over to Mark.
Just a logistical question, Dennis. Do we want to move that? Let's do this.
first. And if it's not giving you what you want, I would not hesitate to use shockwave then.
Okay, wonderful, thank you. Bonnie?
I'm gonna build off of her question. I know with some treatments like PRP, they request that they take a certain amount of time off after that treatment. Is there a similar sort of thing with shockwave where you're obviously creating damage to the tissue? Do you want them to actually stay off of it if you're saying that?
Yeah,
So
you
I'm just going to repeat that again, sorry. So in other treatments like PRP, plasma-rich protein kinds of treatments, Bonnie Suter had a question around whether or not you needed to take time off with shockwave therapy as you do with some of these other forms of treatment.
Yes, you do. You have to cool off for a period. It could be a few weeks. Again, it depends if you will be treated again the following week. And this, of course, is based on your outcome measures and the discussion you have with your patient. But yes, you need to cool your activity. You need this resting kind of half resting period, and then you can resume progressive activities much sooner. And to make a long story short, expect about 10 to 10 weeks post-treatment to see the maximum effect of this treatment.
Okay. Al, and then I'll go to you, Micah.
Also, Dr. Belanger, for the radial versus focused, can you give us an example of what would be a deeper structure for the focus versus the radial, whereas the ultrasound has a more specific guideline?
Good question. I forgot to mention that a colleague mentioned. I talk about the.
No, you can repeat it. Do you mind repeating the question?
Well, go ahead.
So give us an example of a deeper structure that would require focused versus the radial treatment.
Right. Okay. Now, the evidence is pretty clear on that. Is that with radial shockwave, expect a penetration of about 4 to 5 centimeters. Okay. With focused shockwave, you can go as deep as 12 to 15 centimeters. So now, with your anatomy, knowing the fat tissue, try to determine where's the lesion, then you've got everything and you can get to it using either one or the other.
I'm going to follow up, if you don't mind. I have a question about, so one of the, you did a comparison of ultrasound and shockwave. Mm-hmm. And one of the ideas about ultrasound, apparently, is that because fat doesn't have a large protein content, not as much energy will be absorbed, and so you could potentially use it as a deeper heating effect. Now, assuming that that's accurate, does shockwave, you do have to take into account the depth of the tissue with the fat content?
None of the paper I read took that into account.
Yeah.
You just see it, go at it.
Okay.
Whether or not the adipose tissue is half of a centimeter to, none of the researcher, anyway, in a clinician that do the research have taken that into consideration.
Okay. Okay. Now, what did I say, Micah? Or is that what I said? Okay.
Are there any negative effects on the more superficial tissues, like between the target tissue and the surface when using shockwave therapy?
Yes, there is some side effects, but they are minor.
So again, sorry to interrupt all the time. I feel so horrible. Are there any effects on superficial tissues with shockwave therapy as it's going through, getting to the tissue injury site? I would call it collateral damage, which probably addresses part of your question too, I think. But we'll see.
I would call that side effects or whatever you want. But anyhow, there is. And let me list for you a few. First, pain. Expect that the treatment is painful. I don't want to scare anybody, but it's rather painful depending of where you start with. If you already have a painful area, so you may then put a little bit of analgesic cream prior to. Some suggest using cryotherapy because cryotherapy is pretty good in cutting the pain for a few minutes. So you can do a cryotherapy treatment and then go with shockwaves. So that's one, pain. Second, expect some bruising. Expect some edema, some bleeding. So this is the thing that you expect following treatment, but within, you can tell your patient that in a few hours or a few 2 or 3 days, these will disappear, and that's the price to pay to get better. Better than surgery, anyway.
You talked about the success of shockwave therapy, and I wanted to know what exactly you measure success by.
Yeah.
So how do you measure success with shockwave therapy?
Yeah. Success, well, let's talk about tennis elbow. Well, it all depends on the quality of your outcome measurements.
So
Okay.
there's two parts to this question, sorry to interrupt you. One was what is success, and then in respect to secondary injury with surgery, i.e. adhesions between skin, fat, fascia, muscle, does that coincide with range of motion and strength abilities? Because usually when you have adhesions, the tissue has to work around them. So post-surgically, the tissues may or may not work exactly the way they're supposed to, depending on the treatment post-surgery. So what is measured, what is success, and what in patients that have a secondary injury?
Repeat that. Great. Now I need to repeat that. Okay. How do you measure success, and what damage can it do to other tissues? That's what I got out of that.
Okay, well, there's a lot into your question. Let me see if I can answer it. First of all, you apply shockwave therapy, and of course, there is a rehab that follows that. You know, yes, healing is on its way, patient feel less pain, and then it's time to start our stretching exercise and progressive strengthening. So this is not ruled out. No, you're gonna have to take care of this healing tissue and bring the patient back to activity. So yes, shockwave therapy is followed by a rehab program. So I hope that answers your question. Now, the issue of I don't know if I get your question right, but the take home really is that yes, it's going to hurt. Yes, we are creating this new injury, but think as if you were to start all over again with tendinitis that is taken care by you rapidly. The chance of success are much higher than the guy that continue to work as a carpenter and just hurts it over and over again. So again, the success of this therapy is also within how immediate you are in providing it. But again, because it's rather a little bit more expensive, it's not really available right now. I will not rule out what we do, but who knows? Maybe one day we're going to move it to a level 1 at the end, or a level 2 that will follow. But I think the next 5 years, we will have a much clearer picture. I'm sorry I cannot give you precise answers because I just don't know. But I'm watching it carefully, and we'll see.
And I think one thing, there is literature out there looking at some of the outcomes, and I'm happy to share some of the stuff that I've read. But certainly it's one of the new up and coming modalities. And frankly, I've been teaching modalities for 20 years, and there hasn't been anything new really that's actually had decent evidence outside of that, and maybe some of the new waveforms in muscle stim. So those are the two newest things that I've seen coming. And ultrasound, the thing that's new is what's old again, still old. That people still aren't doing it right. So that's why I was laughing when he was saying, okay, Bonnie.
Bonnie, then.
I'm going to move to the SAM off the shockwave.
Yeah.
And it's got to do with, I recognize it's new, but if you look at bone stems used to have their preset lifespan to it. Does SAM have a lifespan to it that we know of?
So I'll just repeat the question. Does SAM have a lifespan like low dose ultrasound units that are bone stimulators like the Exogen units or whatever?
We don't know yet. They're so new. Yeah. Just don't know how long they last.
And I'll go on that. How, obviously they're taking them home, but how fragile are they? Or are they?
Are they fragile?
They're yeah. They're pretty durable. We've had probably 30 come through our lab. We've had a lot of students using them. I haven't had one. I've had one that malfunctioned, but it wasn't because it was misused. So I think they're pretty durable. And what's exciting is in a year, they won't have those wires at all. It'll be Bluetooth. Yeah. So,
Okay, Rita, and then I think I saw Andrew's.
Yeah.
This could be a question for all of you three. You talked about the benefits, or that majority of people use ultrasound, 99% of them for thermal effect. Do any of you use pulse ultrasound for any presentations?
So does anybody use pulse ultrasound because 99% of people use it for its thermal effects?
I said the 99 because he said that, and I trust him. I mainly use it for the thermal. I really can't think of a time. You know, there might be times on an individual who has a acute ankle sprain where you might try the non-thermal effects to try to wake up everything and get the inflammation going correctly in that. But I don't see that used very much.
The evidence is very weak. Actually, I'm looking for it as well. And I just can't find anything. Actually, just to bonafide on what David said, if you look at his study and other studies, it's shown that if you use a pulsed shortwave, and if you set the intensity at roughly 40 watts, because your range can be as high as 500 watts, right? Then you will induce a really important thermal effect in the tissue with that weak of a dose. So, you know, and it's pulsed on top. So just to show you how receptive the tissue are to ultrasound for thermal effect. We thought that was the thermal, the non-thermal. Well, these guys stick probes in there and you see heat. So you cannot say it's mechanical or non-thermal if you see heat. And that doesn't go together. So that's the criterion science. If it has to be athermal, then if you stick a thermal probe in it, you should be recording close to zero. And that's not what we see, even with very low dosed pulsed shortwave diathermy.
Well, and I think it's important to point out too that pulse ultrasound is a time-based factor, so it's shut off. So it heats, and then the whole idea of it is that it's cooling. It's only on for 20% of the time. So that's why you're doing nothing for 80% of the time if it's 20% duty cycle, right?
But
during the 20%.
But I would disagree with that, because the study shows that despite this duty cycle, despite the fact that ultrasound is not running as much as when it is continuous, for example, that nevertheless, you still end up with a thermal effect.
Right.
That is very significant. Right. So to me, it seems like these tissue that we are treating are very receptive for some reason that I don't know to that form of mechanical energy.
Okay.
Yeah, so I have a question with regards to shockwave, and one thing I've noticed, I've had some patients have it, and the prices of the treatment really vary. And then you were saying, like, really you only do about 4 treatments, so after 4 treatments they should see a difference. And then what, like, as far as price goes, what do you find is a price that they should be paying, I guess?
So the question was around price and the number of treatments for shockwave.
Well, I can only speak to what I see in Quebec. Actually, many of my students are using it. Montreal, Quebec City, private clinics. I know the price of the equipment. Now, how much they charge? I know it's more expensive. I don't know about Alberta, but in Quebec, for example, if you see a physical therapist, usually it's for initial evaluation and perhaps a treatment. It's a 1-hour thing, and the rate may range between $80 to $100. Could be as low as that. It could be, yeah. See, it could be as high as 200. But again, if you work in the West End of Montreal, it could be 300, I'm told, because the wallet, you know, is economic, socioeconomic picture of your patient. I'm sure in Alberta, if you have an executive in oil, 200 is a joke, really, because he's got the full-blown coverage, and you can charge him 500, he wouldn't even blink,
What
okay?
about the machines too, like, because they say like, oh, it's a different machine, so that's why it's $200 versus the 75.
No, I think the machine, again, I haven't done a research on that, but I would guess right now that for between 10 and 15,000, you will get a pretty good machine.
Yeah, we have a machine back there. We just bought one, a brand new one, and that we paid $10,000.
Yeah.
So I think the reason why they jack the price up is to pay off their equipment, to be honest.
Because some of them say, oh, it's the machine's better, right? So
No,
I'm just trying to
no.
look after my patients, I want to know.
No, because the treatment is very short. It's amazing. It's 5 minutes. It can be 8 minutes. It's amazing. And of course, you can do a lot of patients with that if you have a clientele. So yeah, you know, we're not in a business of medicine, but we have to cover our costs. And us physical therapists, I can't speak for athletic trainers, but we were not too good into business. And I told my students, you know, after you finish, please take a course in business if you start a private clinic, because you've got a lot to learn. So again, well, because of all those social economics, but I would say this, if you pay a unit 10,000 as opposed to a TENS unit that you pay 200, and then you were to cost out the cost of your treatment, I'll let you do the math, and you will realize that you will charge more for such a treatment.
It also means you might have to start charging $500 for an ultrasound treatment.
So Elaine, maybe you can speak to something she's alluded to already. Is the patient expected to be, at what level of improvement would the patient be expected to be at after, say, their fourth treatment?
Okay. Well, usually you will not even get to the fourth treatment. You may not get there. Maybe one, maybe two. So it's not like a scheduling that you see in other professions where you're hooked for a year. You got a bonus if you continue for another year. I don't know, I think you guess which profession I'm talking about. But anyhow, I'm not here to do professional criticism. I'm just saying, one, and you're asking me, well, how do I know he's getting better? Well, the patient will feel. Again, you're going to have to be on the phone or collect some outcome measurements and determine. This is very good clinical decision making. Am I stopping here? Am I continuing? This is all the nuts and bolts of practice. And this will come with your practice and the cases that you have. If it's a more severe one, you may have to return, treat longer. If it's a less severe case, you know what I'm talking about? It's that kind of a soft thing.
All right, Stephanie, I think.
My question's for Dr. Leroux. With the NEMS being effective for 6 weeks post-injury, like most effective during that time, do you think it would also have implications for maybe youth athletes or children athletes that don't have injuries, but maybe haven't had that muscle education that people post-injury also have that?
So the question is, with muscle stim being most useful up until the 6-week period, would muscle stim be useful with perhaps children that haven't fully developed their muscles?
Yeah, similar in the same strength building.
In the same strength building capacity?
This part comes in handy, it gives me a chance to think.
That's what I'm trying to do.
He's paid to do that.
I went into PT school thinking I was going to go into pediatrics, and for a variety of different reasons, I was overwhelmed by it. And so this reminds me of why I didn't go into pediatrics. I'm not aware of any evidence that says that the conventional applications of NMES, as I tried to describe today for strength or retarding atrophy, would apply themselves as directly to a pediatric patient who is developing, well, you didn't use the words motor delay, but let's exclude maybe neural causes if we can, and say it's just, I don't know, I'm not sure what to call it, but lack of development of muscular strength. I'd have to put it in a different category and say that there's no There's no evidence to support doing that, but if it were looked upon as what is traditionally thought as neuromuscular re-ed, which traditionally wouldn't use the contractions at maximal force, then there's every reason to think that it could be used to facilitate that. And in the neurologically involved pediatric population, it gets categorized under this acronym FES, which I don't subscribe to or advocate for, but everyone knows kind of what we're talking about. Then maybe that'd be a cause for use. Certainly worth exploring. Excellent question.
And perhaps, just to add, a feature that we often forget when we do NMES is that when we depolarize the motor nerves, the impulses are traveling efferently, they are traveling towards the muscle. But think of everything that comes back towards the spinal cord. And this is called neuroplasticity. And there is some kind of evidence there. I'm not aware of the details, but we should keep that in mind, that this perhaps could help a child that is developing and could help with motor neuron, synaptic organization, be able then to drive them with the cortical neurons later. I don't know, something like that. But it's reasonable to think that way, I think.
All right, Mike.
I have a question about phonophoresis and how effective you think it is, and with the SAM system. Is that possible?
So the question is around bone bruises and the SAM system, and if whether or not it might be effective.
Phonophoresis.
Oh, phonophoresis. My bad.
As far as the SAM being effective for phonophoresis, that's an excellent question. I have no idea. That's that might be something they need to look at. They've got a hydrogel already that is the ultrasound basically, and so they'd have to figure out how to put lidocaine or hydrocortisone or something inside one of those to do that. And do I think it's effective? That's a good question. I've read a lot of studies. Some say it works, some doesn't. My gut feeling, and I'll have this guy chime in anytime he wants. I think we're using the wrong frequency. I think if we try 90 kilohertz or 45 kilohertz, we might be better with phono, but I don't know.
This guy is Dr. Bélanger.
That's right. If you look at the use of electrophoresis in medicine, surgeons, pediatricians use that to calm down children before they do the injection. So this is well developed. This is well documented, and we know we can induce local analgesia with electrophoresis. Come on, that we know. So they use it too, but they use different frequencies. So I agree with David that we may not be using the right frequency to do electrophoresis. Frequency, sorry. I'm talking about phonophoresis, not electrophoresis, because it's a continuous current, obviously.
It's interesting. I'm just going to chime in here because I had a good conversation with my pharmacist the other day, and I said, so, you know, I'm an athletic therapist, and we use things like phonophoresis, and he said, well, I have no idea what that is. So I described to him what it was, and I said, so in Canada, they're allowed, at least in Alberta, they're allowed to prescribe certain drugs. And so my question around it was really, can he prescribe the drug to me so I can use it in application, or does it still have to go through a physician? And so when I described to him what phonophoresis was, he said, well, that's kind of useless. I don't know why you do that, because from my perspective, it has all the right biochemical substances in it in the way we create it. We create our mixture, and it's intended to drive into the body already. So to me, he said, that's like overkill. So it's the first time I had ever heard, totally different lens that he's looking through, first time I had ever heard a different perspective on, well, is phonophoresis useful? Because I thought it was quite useful. I've used it often, and so it was just a different take on it. Yeah.
Well, you know, if you talk to pharmacists, the thing that you rub on your thing, that's passive diffusion in the pores. Here we're cranking energy on top, electrical or ultrasound, and we crank it further, faster. So you should not be surprised of that.
But he was very surprised. He said, because he believed in his product and he thought that it was going to drive it in just as far. And I said, well, no, there's lots of good evidence. And anyways, it was just an interesting take on it.
Well, let's remember that in the history, there was the farms it was that profession that characterized dexamethasone as positively charged.
Fair enough. Melissa, and then Bonnie, and then I think that's all the questions we can take.
I have one question on shockwave and one on the NMES. With the shockwave, a lot of us ATs do manual therapy like the Graston technique or guasha, the myofascial tapping. How would the shockwave therapy compare to those modalities for the more superficial lesions?
Can you repeat the question?
I will.
Okay.
And I want to say, I've been thinking the same thing, but I was embarrassed to ask. I was going to ask him over dinner. So thank you. Because all of our people use Graston.
So, well, there you go. So if you compare shockwave therapy to other more manual therapy techniques like Graston or cupping, do you know of any studies that are comparing those two things in the outcome measures?
I'm sorry to say I'm not familiar with those techniques, but I'm familiar with Cyriax, transverse friction. I would say that if you go back to the effect of a mechanical energy on biological tissue, you have to go back to the late 1800s with Wolf, the German, that showed that a bone will heal when you put a stress on it, the piezoelectric effect. So from Wolf, we moved on to Cyriax. Cyriax in the 1950s thought that by doing pressure, strong pressure, it will help. He was right. And now we have a modern technology to push this further by means of, but I'm sorry, I'm not afraid of the two techniques or method that you have.
So Graston is taking a metal tool, a chiropractor created it, and then he quickly copyrighted it and trademarked it so he could make a lot of money. Oh, that's just my editorial. Anyways, so he took a metal tool and they basically go in and scrape tissue and create damage and break up things mechanically. The same way that you just described Cyriax, pretty similar. Yeah.
The myofascial release is similar to it's like negative pressure, and then what happens is because there's adhesions, it lifts the skin up and then you move it, so it's creating an inflammatory response. And same thing, it does the same.
We're into pressure therapy. Here it could be low pressure, low frequency, high energy, lithotripsy, and all that. It's all about mechanotherapy.
Well, and I'm sure there will be, I'm not aware of any studies because shockwave is still relatively new in the research world, but I'm sure there will be studies out soon about it. So good question. And then you had a...
And then my other one is with the NMES, you mentioned it's most beneficial in the first 4 weeks. Is that just with post-surgical patients or is that across any injury?
No, so this is from the literature. That 4-week window seems most ideal, 6 week, up to 6 weeks maybe. It's really for post-operative or post-injury, in which patient, subject patient shows activation deficits. So it could be, joint swelling that's inhibiting the quadriceps. That'd be a period of time. If the patient, bottom line, if the patient cannot volitionally activate, then the evidence substantiates the use of energy.
And how early would that be taken? When we're looking at the inflammatory process, can we put it on day one or do we?
Well, if we consider post-operatively or post-injury, and I'm going to just use some of the stereotypical examples of knee injury, the acute, the inflammatory response is here, and we're trying to stimulate motor tissue here, or nerve first, polarizing nerve for motor activation. Probably there's examples that we could get to, but we're not applying NMES over inflamed tissue.
So the more distal or proximal to that area, we can find.
Yeah, we consider most of the time we're talking, not most, but a lot of times, if we're talking about post-operatively ligament, meniscal, etc., joint injury, the muscle that we're stimulating is likely not contributing to that inflammatory process at that ankle or knee, whatever it might be. I'm sure we could come up with some examples where maybe we want to consider that otherwise, but if we're working on the muscle activation because the patient can't, and I don't think that's as big a concern. Now, one example that does come to mind, because I continue to think about this while our programs are running in the background. Obviously, you wouldn't want to, in cases of, say, I don't know, an ankle sprain comes to mind, you wouldn't want to do, you would not want to bring blood flow to the area if we're having a vascular compromise that's causing leakage. So I wouldn't stimulate, the posterior tibial group with an acute ankle sprain when it's in the bleeding out stage. Yeah.
All right, Bonnie, and then because Dennis did most of the work to organize this, we'll give him the last question.
I actually have two. One short, one might be longer. Can I ask both of them?
Yeah.
In the province of Alberta, with the lasers, we have to have, there's provincial regulation that we have to basically.
Compliance standards.
Compliance standards. Is there going to, do you know if there's such a thing for the shockwave as well?
So the question is, are there any compliance standards with shockwave?
Not to my knowledge.
And Larry says no too. Larry should know this. No?
There hasn't been anything.
No. Health Canada hasn't. No.
Okay, so that was number one. This is the longer one. I worked with an orthopedic surgeon who really doesn't believe in a lot of things. Mark's laughing. He doesn't believe in a lot of modalities. And his concern is always that there's more vascular proliferation than normal when we use modalities, which would then end up weakening the tissue. Can any of you make a comment on that?
I don't know many orthopedic surgeons that know much about modalities. I'm sorry, I really don't.
What he just said is a good example of what he just said. It makes no sense.
That's the fight that I always have with him when I'm working with complications.
So the argument is that there's
more
vascular proliferation?
There's too much vascularity in the area, which then will lead to a weakened tissue in the end. That's
A weakening of the vascular tissue?
Weakening of
the tissue that is created in the end. So the scarring or the healing process, etc.
So a ligament, for example, there may be too much vascularity to the ligament.
Yes.
It seems counterintuitive to me.
Ligament doesn't have much to start with. That's the problem.
If creating too much vascularity is a problem in that case, I can think of several patient groups where that would save them from amputation. So I'd like, if that were true, I'm pretty sure we'd be utilizing that in many other cases.
I have a question for you. Ask this surgeon this question. If he says that, too much vascularity, ask him. Every time you open the skin, what are you doing? What are you doing with your electric catheter? You want to coat around. You're doing a lot of mess in there, right? So ask him. And if he thinks it's too much for the orthopedic field.
She'd have to wear a helmet to ask the question.
Okay, Dennis gets the last question. Okay, when I was in school,
I had a lot of supervisors that combined some of the modalities. Some of you might have seen this as students through your placements, either here or for the virtual crowd in Ontario. Electrical stim, whether it be IFC or neuromuscular electrical stim with ice or with a hot pack, an ice bag or a hot pack. When I was in Florida, they talked a lot about combining, I think it was muscle stim with ultrasound. And so I just wanted to see if you guys can comment on combining some of the modalities. If there's research on it, if it's effective. So any comment on combining some of the electrical modalities?
I think first and foremost, we have to keep in mind precautions, contraindications, and impaired sensation is generally recognized as a precaution for electrical stimulation, primarily for skin integrity. But at the same time, many clinicians, maybe more astute or aware or informed clinicians, may use ice with electrical stimulation, or NMES, I'll stick with NMES, because of the discomfort associated with contractions. But the evidence doesn't really substantiate that because the pain apparently isn't generated from nociceptors that are affected by the cold or ice. So I'm not sure that it's necessarily warranted. I think if a person wants to apply ice before the administration of NMES, that's probably maybe a little bit more reasonable route to go. Although I'm not aware of any evidence that substantiates the co-application of the two. And personally, I have no experience, and also I've never heard of the co-administration of NMES with ultrasound. But obviously, combo in the realm of electro pain modulation is still not gone yet.
Well, I would concur with him. I have the same feeling. I mean, if you ask me personally, mixing up agents, or you call it modalities, to me, it's a no to start with. First, assess carefully your patient. Determine what do you have as a problem. Then understand your agents and pick up, pull out those that you think may be useful to manage this particular problem and this particular problem. And then you can think of mixing them up. But my feeling, I agree with him, I haven't seen any benefit of mixing everything up. And it looks bad, honestly, I'll be honest with you. I mean, to keep a patient for an hour and submitting them to 3 different modalities and then letting them go, that was yesterday. I'm thinking today, I'm thinking of tomorrow. And the better we understand what we're doing, the better we use the proper parameters. We've got a long way to go, It's a difficult field. There's some calculations to do, there is some thinking to do. But for too long, we haven't done that. We've just said, okay, ultrasound, 5 minutes. Short wave, dangerous. Short wave, whatever. What I'm saying is, I agree with him, and I don't see much value into this.
Well, I'd like to add something to that, because it's very, very common practice in our profession after practice to do ICE and STEM. We do interferential and ICE at the same time. And I don't see anything wrong with that. Others, it's a problem. What do you think? I mean, they're both there to help relieve pain, and there might be a little bit of inflammation going there, so I don't have the problem with the ICE on there to help curb that somewhat. I don't know. What do you guys think?
Well, in the case you just explained, it would make sense. That's what I was saying. Assess what you've got, and if you have 3 or 4 therapeutic outcomes, pull out those agents, and then decide which one you're going to apply. And mixing these 2 in this case would make sense to me. Okay. But what I'm saying is that don't mix just for the fun of mixing, thinking that more is better. More is not always better. Size may matter, but more may not matter.
Well, thank you for entertaining the questions. Thank you all for asking the questions. And for those of you online, thank you for asking the questions as well.
Just before Dennis wraps up, I have the honors of saying thank you to the number of people that have organized today and participated. So first of all, thank all of you. Thanks to all of you that have come, alumni and otherwise, for coming today and participating. But I also want to thank the sponsors again. I know we flogged them to death, but Larry, thank you very much for being such a great partner. The Alumni Association, the ADTA, so a lot of you are ADTA members, so it's your association that helps support it. But 2 people in particular that really pulled this off, Dennis and Bria, have done a tremendous amount of work to pull this off today. So thank you. I was supposed to give you your gifts, the speakers, to thank them, but apparently you already got them. Again,
what gifts?
I'm just going to ask Rita to come down to make just a couple announcements before we sign off, before we say goodbye to you folks here in the room, and before we sign off from the people online.
I just want to remind everybody that we have a social going on. I'll start right away. Social is just going to be at the old local 002, just on the east side of campus. We're going to cover appetizers, so come eat, come celebrate, come have a drink. Our guests are more than welcome to come join us as well. You can maybe agree to come, and you'll get a chance to talk with them more one-on-one. And I want to see each and every one of you, if you're an AAT member, tomorrow at our AGM. Starts at 12:45. If you're interested, please come forward. We have a SAT meet and greet that starts at 9:15. If you guys would like to come for that. And also, we have some of our students have lab 30. Only one lab presenting tomorrow. Alcar and color out. Come share on 10:30. Student research presentation. Thanks for coming.
Let's read it. Let's read it.
Yeah. And then last thing, I guess just for our virtual audience, goodbye. Thank you. And I'm going to ask Charlie to swing the camera around so all of you can say hi and goodbye to our virtual audience as well. Yeah, selfie. Woo!
Thank
Thank you for coming, everybody.
Good job. Now you can